Okay. Good morning, ladies and gentlemen. Welcome to the Bombay Orthopedic Society Master Cares and Master Shares program, the first of this year, that is the calendar year 2020 to 2021. Normally, we would have had met at Cooper Hospital, had some samosas and chai, and enjoyed this program on office orthopedics. But with the current situation as it is, you are sitting at home and watching this webinar from us. And what I would request is that you should pick up your cup of hot coffee or tea from the kitchen and get some snacks and sit down for this wonderful seminar that Dr. Harshad Argekar and his team have organized for us. We have a host of eminent panelists who are specialists in their own fields from across the city and across the spectrum of Bombay Orthopedic Society, who are going to speak to us on various aspects of practical aspects, I would say, of office orthopedics. And so I'm sure you will enjoy the program. Without much ado, let me hand over the mic to Dr. Harshad Argekar, who is the coordinator of the show today, and he will moderate from here on. Thank you.
Good morning, everybody. Welcome to the first series of the Master Cares, Master Shares symposium, which we organized in the Bombay Orthopedic Society. The topic for today is office orthopedics. The program I have designed so that we focus ourselves to clinical examination, history taking, and basic minimum investigations so as to reach a diagnosis, a working diagnosis of what the patient has and how you can start treatment earliest. So this session will involve pure practical clinical points. It will not involve too much of theory. It will not involve any kind of investigations. For sake of convenience, we have divided into 4 sessions. First session is on the shoulder, second session on the spine, third session on the ankle, and fourth session for the knee. We hope to have 1 hour dedicated for each session. After the entire session is over, we will be open for question answers. Questions, those who are on YouTube can put it on the chat. And we have 2 moderators, Dr. Satish, Dr. Gautam, as well as Dr. Kini and myself. We will update the panelists for the questions. And you can direct your questions to the panel or to specific people. And we will put your questions across to them and let them answer. So I would like to first invite Dr. Hetal Chiniwala to start the session on the shoulder. I request Hetal to share his screen. Dr. Hetal is going to talk about differential diagnosis of pain in the shoulder. How do you identify the cause of pain and how do you start treatment for it? Hetal, you can start.
So I think, can you all hear me? Can you all hear me?
Yes.
Yeah. So I'm going to start. My topic is on shoulder pain is office practice. Now, sorry, it is not moving. It is not moving. Okay. The shoulder, as we all know, shoulder pain can be most confounding. When I passed out my MS, I had no idea what the shoulder examination is. Earlier were the days when the ignorance was bliss. Every shoulder was a frozen shoulder. Patient would suffer in silence because everyone would give the same diagnosis. There was no knowledge, so there was no confusion. Slowly came the time of onslaught of MRI and arthroscopy, and with that came the onslaught of diagnosis. Whether it's a frozen shoulder, cuff tear, tendinitis, slap tear, and sometimes even after all those diagnoses, you will wonder whether it's really a shoulder pain or no. So our dilemma is what reasonable clinical diagnosis we can offer and what reasonable practical treatment we should give it to the patient. So my 2 points were very important is shoulder pain. When patient comes to you, it is not a shoulder pain. Patient comes to you with arm pain. A shoulder is a site which is shared by many structures for pain. The pain in the arm can be from cervical spine, it can be from thoracic outlet, it can be from glenohumeral and shoulder joint complex itself. And second point is that shoulder joint is not just a glenohumeral joint. Just see this video, shoulder joint, there is abduction which is occurring at glenohumeral joint. Then there is elevation of scapula which is occurring. There is rotation of shoulder. when the scapula is elevated, there is acromioclavicular joint and sternoclavicular joint which moves. And all this is brought about by various muscles around the shoulder, the muscles which start from all over the spine to scapula, from scapula to ribcage, and from the scapula to humerus bone. And hence, no examination or no clinical evaluation of shoulder is complete unless and until you have examined each and every aspect of this. So let me first clear out a dilemma which comes in an acute non-traumatic shoulder pain. Now, for my clinical practice, a patient with an acute non-traumatic shoulder pain is always a calcifying tendinitis unless and until proved otherwise. Patients usually come with tear in the eye. Even fracture doesn't produce so much of pain. All the movements are restricted. Usually, X-ray picks up the diagnosis, reassurance, analgesics, and it's a self-resolving structure. However, there are some patients. For example, this 40-year-old lady with acute pain since 2 days. I looked at the X-ray. There was no calcification. So what? I was wondering what it could be. But then I examined the patient and I saw that the tenderness point was in front. And then I went back to the X-ray and I saw that there was some fluffiness on lesser tuberosity. And that is where I did an axillary view, a small, and then I found this subscapularis calcification. So subscapularis calcification has to be kept in mind as a clinical suspicion because it is more common than not. The moment you start suspecting, we'll start seeing many patients who are not supraspinatus calcifications, but subscapularis calcification. Now let's go to the realm of chronic arm pain, which I call it not shoulder pain. So first thing I do is ask where the pain is. If it's in the nape of the neck, whether it radiates to the arm, then we know that it's cervical spine or thoracic outlet. The pain usually when it's in the front of the arm, it is initial adhesive capsulitis because of the involvement of rotator cuff. The pain on the side of the arm is usually from glenohumeral joint. And when the patient points the finger, I know it's a acromioclavicular joint. Acromioclavicular joint pain can be a very pinpoint precise pain. History may not always help because degenerative cuff tear may not give you history of injury, and diabetes always doesn't mean frozen shoulder. Cuff tear is very common in diabetes because of lack of vascularity. So how do I do it? First thing in my patient that I examine when I know it's a shoulder problem is the rotation. Rotation is my first key to the diagnosis. I do this simple external rotation test, and if this external rotation is restricted, I know for sure it is a frozen shoulder. It almost certainly tells me it's a frozen shoulder. In patients with cuff pathology, usually it is the internal rotation which is painful because of the tightness of the posterior capsule. External rotation is reasonably free. Second thing I examine is forward elevation. I'll let the patient lie down and see in frozen shoulder, it may be painless, but a firm endpoint. The shoulder will not go beyond certain thing. It's a firm restriction and I know that this is a frozen shoulder. Whereas in a patient with the cuff and other problems, the forward elevation may be painful, but it will go usually the whole range. Then I do my routine cuff test, simple supraspinatus test, Jobs test for supraspinatus, infraspinate for infra. I just keep the arm by the side of the body and check for the infraspinatus strength. And I complete it with the subscapularis testing by just asking the patient to lift off the arm. These are the basic tests which you should do. Sometimes I also check the patient if the pain increases with supination, then I know that it's coming from the bicep. So you first check it as a Jobs test and then you supinate the forearm. That there is pain, it's a biceps pain. So my diagnosis is very clear. When I have a restricted forward elevation, I have a restricted external rotation and reasonably good cuff, I know it's a frozen shoulder and I'm very happy because I know that the treatment is straightforward, simple, home-based, passive stretching exercises, and it works in 95% of the patient. I don't have to worry. Few tips I give in to the patient is that do not do any exercises which is against the acromion and gravity. Do not use any modalities like diathermy. Do not send them to physiotherapists. They don't need physiotherapists. Simple home-based exercises is what does the trick. I'm sure Mihir is going to entail upon this later on. Now, when the patient has a painful internal rotation, painful forward elevation, either painful or weak cuff test, I know it's a cuff pathology, and then the treatment goes in those directions. Usually the clinical rehab works very well, which Mihir will emphasize upon. However, there will be some patients who are still painful. They have reasonably good range of motion, they have reasonable strength of rotator cuff, but still they will come with pain. These are the patients you should always look for scapula. Whenever I am confounded, I always look at the scapula. Scapula is the boss of shoulder. It answers the most unanswered questions. It is the most unexamined structure. And I always look at it in any arm pain. You can see this patient has a very subtle, protracted and elevated scapula. A dyskinetic and weak scapula is very common root cause of all the shoulder and cervical spine problem. A weak scapula can overstrain the cervical spine, overstrain the shoulder and elbow. You will be surprised to see that 80 to 90% of your tennis elbow patients have a weak scapula. Case in point, this is a 40-year-old male, neck pain, referred to left arm, not relieved with analgesic, steroid, modalities, exercise, etc. MRI of the cervical spine showed degenerative cervical disease, not really needing surgery, cuff was degenerative. What did I do? I just examined, see he has a restricted cervical spine movement. You can see here, the scapula on the left side, it is tilted, it is protruded. You can see his hyperlordosis of the spine. And you can see this clinical test. The moment I put load, the scapula pops out. This is the test. I know that this is a scapular problem. And second thing I do is scapular stabilization test. Wherever is the tender point, I'm sorry I pushed it hard because I want taking the video. Whenever I have a tender spot anywhere, whether it's a biceps or anywhere, I do this Jobs test. You can see it's a painful supraspinatus, it's slightly weak and painful. What I do is I try to hold the scapula and again repeat the test. And when I do this, I know that not only patient's pain subsides, the strength also improves. So this is a weak scapula. Good scapular strengthening, balancing is the key to complete recovery. I see so many patients who have come to me with 1 MRI, 2 MRI, 3 MRIs, nothing significant, but their scapula are weak, which is not being diagnosed. And once you put them on rehab for 2-3 months, they definitely recover. Not only scapula, but you should always look at the whole body, because our whole body is a kinetic chain. So weakness anywhere in the kinetic chain will give you shoulder pain. Imagine this patient, if you have a flat foot, if you have a genu valgum, if you have a weak pelvis and a gluteal muscle and a weak spine muscle, your shoulder drops and it gives rise to shoulder pain. These are the patients who will not show you where MRI or any investigative modalities will not show anything to you. The patients will keep suffering unless and until you examine the patient as a whole. And these are the patients with little rehab, little changes in footwear orthosis, they do really well. So, see, look at that patient which I showed earlier. This patient with had a weak scapula, and you can see the lordotic and the scoliotic spine. And when we unless and until we correct this, the patient will not get all right. So my summary is, don't look at shoulder with just eye on glenohumeral joint. Any eye pain is due to weak break in the link of the functional kinetic chain of the body. And most treatment decisions in shoulder especially in shoulder are based on clinical presentation, not on MRI or radiological finding. You don't need to be a shoulder surgeon to be a good shoulder clinician. Simple examination rules, simple treatment will take care of most of your patients with shoulder pain. It's like I always say, though our children grow up, they become handsome, but they are cutest when they are little. So clinical examination, the age-old art, is always better than any advanced investigation modalities. No amount of musculoskeletal radiology can replace our clinical art of shoulder examination. Thank you.
Thank you, Dr. Hetal. So that was a very nice and sweet presentation on clinical examination and differential diagnosis. We'll be taking questions on Hetal's talk at the end of the shoulder sessions. So those who have questions, please put it on the YouTube chat, and our moderators will ask the questions to the panel once the session is over. So now I call upon Dr. Mihir Patel. Mihir is going to talk about conservative management or non-operative management of shoulder, focusing more on exercises and rehabilitation. Mihir, you can start talking. Mihir, you're on mute. Mihir, you're on mute, so you need to unmute yourself.
Okay, can you hear me?
Yes, go ahead.
Yes, I'm Dr. Mihir Patel. Good morning to all of y'all. And I'm going to talk about non-operative management of shoulder pain. The aim of treatment, as of all know, is to first give pain relief to the patient. And once there is pain relief in the shoulder, we have to get the function back to what it was before the patient came to us. So there are some principles that we need to follow. First part of this treatment is going to be controlling the pain, and for which we need to identify whether the pain is of the inflammatory type or mechanical type. Exercise, first principle, no exercise can be done when there is pain. Again, when we start exercises, there are two types. It can be either stretching or strengthening. And we have to understand that during the course of treatment, there are going to be acute exacerbations of pain for which we may have to go front and back with respect to a treatment. Once we finished a history, clinical examination and radiology, you will identify that when a patient comes to you in the OPD, about 90% of these patients having shoulder or pain will have some kind of pain or stiffness. There will be only a bracket of about 10% which will have only stiffness and no pain. So how do you go about taking care of these patients? The patients having pain, the first thing we do is we need to counsel the patient. We need to tell them there is some kind of problem in the shoulder, there is some kind of swelling, probably there may be some kind of tear. We have to tell them that we will be giving the patient some kind of medications, rest, ice, and the duration of the treatment may go on anything from 1 week, 1 month, 3 months to sometimes even 6 months, so that the patient has some realistic expectations from us. The first and foremost thing that needs to be done has to stop any kind of exercise the patient is having. Because most of these patients that come to my OPD, some family physician or some family physiotherapist has given some kind of exercises which are going completely wrong. So all those exercises have to completely stop. The next thing is to start ice therapy. So the patient is advised to apply ice to the shoulder about 3 to 4 times in a day, 10 minutes each time. I will usually start some kind of anti-inflammatory medication, and my favorite is an NSAID, which is tablet aceclofenac 100 milligrams twice in a day for about 5 days. I will usually avoid this medication if there is a contraindication like a chronic kidney disease or uncontrolled diabetes, or if the patient is not willing to take any kind of medications. I will add some kind of analgesic in form of paracetamol, tramadol twice in a day for about 5 days, and all these patients are then asked to follow up in my clinic after about a week's time. When they come to me next time in my second visit, the only question I ask them is, how is your pain? You'll realize that about 40% of patients start feeling better. But there is a bracket of 60% who will say, okay, sir, there is no difference, or probably the pain has even increased. These 40% who say they're feeling better are shifted into what I call is exercise protocol, which I will be talking in my second part of my talk. But the 60% who have some kind of pain, even now, I will counsel them whether they're taking the medications properly, they're doing the therapy properly, and most importantly, they're not kind of doing any kind of exercise at home. Continue the same treatment and ask these patients to come back after about a week or 10 days time. When they come to you on the third time, that is the second visit, of the 60% having pain, 20% start feeling better, and remaining 40% still say there is no change in their pain. The 20% who are feeling better are shifted into what I call exercise protocol. And the painful group is this is the first time now I'm going to ask for a special investigation like an MRI scan and some blood reports. So why MRI scan? I need an MRI scan now because the patient has come to me for a third time. The pain is not going away, the patient is not happy, and I need to identify what I'm dealing with. So I need to know the extent of tendinitis, bursitis, any calcification which probably I've missed on X-ray, any possibility of rotator cuff tear, and to see whether there is element of capsulitis. Now that I have an MRI, it is much more easy for me to counsel and explain the patient what we are dealing with and how the treatment is going to go forward. And very importantly, I will be able to identify the bracket of patient who may require early surgical intervention, especially for patients who have a full thickness rotator cuff tear with stiffness or a partial cuff tear almost ranging more than 75%. In blood test, I'm going to ask for a CBC, ASR, CRP for future comparison, sugars to identify patients who are yet not diagnosed diabetic, and a renal and hepatic profile because these patients are going to be on some kind of oral medications. So what treatment do I offer them? Now when the patient comes to me for the third time, the first thing again I stress that they need to stop any kind of exercise, any kind of home activity they are doing using that shoulder. I will now shift them into some kind of support. So my favorite is an abduction brace. You can see in the picture that this keeps the shoulder in neutral rotation. I will again insist on ice therapy 3 to 4 times in a day, 10 minutes each time. This is the first time in my treatment that I'm going to offer the patient some kind of injection. So my favorite is a subacromial steroid injection, choice being triamcinolone with lidocaine. We have Dr. Mutha talking beautiful about this injection technique, so I'm not going to go into details. There will be a bracket of patients who will deny injection, either because they're scared, they don't want a needle, they don't want to pay up. So these will be the patients I would counsel them on some kind of oral steroid. However, I'll explain to them the advantage, disadvantage of both. And my favorite steroid orally would be a tablet Deflacort, 6 milligram, about 3 times in a day for the next about 5 to 6 days. I will always combine some kind of analgesia in form of paracetamol, tramadol, now 3 times, and then shift it SOS once the patient starts feeling better. This is the first time in my therapy that I'm going to introduce physiotherapy. Please note, physiotherapy, there is no exercise that the physiotherapist is going to do. She or he is going to only offer modalities like shortwave diathermy, TENS or ultrasonic, because these modalities have very strong anti-inflammatory activities. I ask these patients to come back after about 10 days. When they come to me on the 4th visit, of the patients, 40% having pain, 30% start feeling better, and I shift them to exercise protocol. The remaining 10% who still don't feel better, they just don't turn up. Either they change doctors, they shift into alternative therapy, and there's nothing we can do about them. So now that we've controlled pain, we come into the second part of our treatment, that is exercise. Now there are two types of exercise we have to understand. There is a stretching exercise, the aim of which is to gain range of motion. And after you've got good range of motion, we start strengthening, the aim of which is to improve the power of the muscles around the shoulder, namely the deltoid and the parascapular muscles. You have to understand during any stage if there is pain, the exercise has to stop, and exercise can resume only after pain control. So passive exercises, the aim of passive exercises is capsular stretching. Please understand that we are only going to do forward flexion, external rotation, internal rotation, and abduction is never done. Exercise can be done either supine or in standing position. So this exercise, first exercise is forward flexion. You have to understand that the patient is using his other hand and passively taking the affected shoulder into forward flexion. This stretches the inferior capsule. I always start these exercises in supine position because automatically the scapula is stabilized. And once the patient starts feeling better and is confident, you can shift into standing exercises. External rotation stretches can be done, as you can see. Either a scale or a ruler can be kept in between the two palms, and with the arm next to the body, the opposite hand pushes the shoulder passively into external rotation. Again, doing it in supine position helps very much because it automatically stabilizes scapula, and many times the patient may turn his body when he's doing external rotation, giving a pseudo external rotation which is not occurring at the glenohumeral joint. The third exercise is internal rotation stretches, which stretches the posterior capsule. So you see the patient holds both the palms behind the back and pulls the affected hand across very slowly till he gets a little bit of pain, hold it there for about 10 seconds and he comes back. Many times the patient may not be able to hold the two palms together, and then this is the time that you ask them to hold a towel in between the two hands and do the internal stretches, as you can see. Once the patient has gained some kind of movement, especially at least 90 degrees, I start this elbow to elbow exercises because this exercise stretches all parts of the capsule together. So when the two elbows are coming together, it stretches the posterior capsule. When the elbows goes away, it stretches the anterior capsule. And this exercise works very well for patients who come to you for the second or third time in the exercise protocol. As Hetal said, along with glenohumeral joint, we have to start scapular exercises. The simple exercises that we can allow are shoulder shrugs, which basically work on the upper trapezius, and protraction retraction of the shoulder, which works on the serratus anterior, the rhomboid, the middle, and the lower trapezius. Exercises are advised to be done about 3 to 4 times in a day, followed by ice therapy about 10 times. Anti-inflammatory medications can be overlapped for a 1-week period, and then I advise the patient to take SOS whenever he gets pain, and the patients usually come back to me after about 2 to 3 weeks. Now, when they come back, they fall into 2 brackets. There will be one bracket of patients who are doing very well. These patients will be advised to continue the same exercise protocol, and I keep them into monthly, 2-monthly follow-up. And moment they get almost complete range of motion, I shift them into the strengthening exercises. Now, please understand, strengthening exercise is something which I would always advise a physiotherapist to do under her or his counseling, because it involves therabands, it involves pulleys, it involves some kind of weights. But obviously, these strengthening exercises are done under strict surgeon's supervision. The patients who are not doing well, we need to identify why they are not doing well. So if there is pain, we need to stop the exercises, go back into pain control. This is the time when I would like to do an MRI scan of blood reports to see whether are we looking at a patient with a cuff tear, are we looking at a patient with some kind of capsulitis, and this will be the time when I will offer a second subacromial steroid injection. If the patients are not doing well because of stiffness, we need to confirm their compliance with respect to exercises, because most of the patients, once they start doing well, they forget all the exercises. We need to control pain. Again, this will be the time when I will ask for MRI or blood reports and restart the exercise protocol. So when do we break this non-operative treatment? We break the non-operative treatment in patients who have a full thickness rotator cuff tear with stiffness, not feeling better on this conservative line of treatment, or a partial cuff tear more than about 50 to 70%. The second indication of breaking this non-operative treatment is capsular thickening. So we know that there is a thawing phase or a non-painful phase of adhesive capsulitis. And when these patients don't do well for at least 6 months to 1 year on the exercise protocol, I would offer some kind of capsular release. And there will be a bracket of patients who say that we want early recovery or early range of motion. These will be the other bracket in which I will offer early surgery. So to conclude, I would say that 80 to 90% of OPD shoulder pain can be very effectively managed conservatively. Special investigations are not needed in all. Pain control is the single most important criteria before we start any kind of exercises. And the two types of exercises are stretching, after which we can only start strengthening exercises. Thank you very much for your attention.
You are unmuted. We can hear you very well, Harshad.
First thing I would like to show is 2 slides on how to get true AP views, good axillary lateral views, and good Y views. So this is how all of us would agree. Our technicians will take an AP view, because of which there is significant overlap between the glenoid and the humeral head. But we want a true AP view where the entire joint profile is seen, for which we need to make sure that the X-ray beam is directed towards the coracoid tip and the patient is tilted 30 degrees such that the scapula is parallel to the cassette. Only then we can get a true AP view like you see in the video. Axillary lateral view all over the head, how we take it. Scapular Y view is something which requires a bit of skill. So this is the position of the patient. What we need to make sure is that the X-ray beam is parallel to the spine of the scapula, like you see on this video. And that's the kind of Y view which will tell us, in this case, for example, it's a very prominent and a hook patron view. So in a patient who's got dislocation or any bony injury, you can do a well-formed axial lateral view, wherein you place a cushion under the elbow and you can change the position of the X-ray gantry such that it points towards the axilla. Now, common conditions which cause pain around the shoulder, obviously the first thing that comes to mind is rotator cuff. All of us know about them. What are the conditions? There can be tendinosis or calcific tendinitis. There can be a partial tear or a complete tear, to put it into perspective. So let's talk about calcific tendinitis, something which causes excruciating pain and tells you the sudden onset severe pain in the middle of the night, and the patient calls you. And this is a spot diagnosis. On a plain X-ray through AP, you will see the calcific mass. But always get an axillary lateral view, because that tells you whether you are in the anterior half of the acromion, meaning whether you are under the supraspinatus, or in the posterior part, which tells you you are more like in the posterior part of the supraspinatus, or in the infraspinatus rarely. So the axillary lateral view tells not just the presence but also the location. Similarly, you can check the MRI for the location of the calcific mass. On a true AP view, we need to understand the concept of Gothic arch, which is nothing but the Shenton's line of the hip. So when you draw a line like you saw in this image, which goes from the inferior border of the humeral head, it matches the inferior border of the glenoid. Why is it important to know this? Because if there is a partial tear or a tendinosis or any condition, or a complete tear for that matter, or any condition which affects the depressor function of the humeral head of the rotator cuff normally depresses the humeral head. If it is unable to do that, the head will hide up, causing break in the Gothic arch. So simple plain X-ray, when there is a break in the Gothic arch, you know there's something wrong with the rotator cuff, which will evaluate further by doing a MRI. The MRI will show either tendinosis or calcific tendinitis like we saw, or it will show partial tears. The partial tears are of 3 types. One is the bursal surface, meaning the articular surface intact like you see in this image, but on the bursal side the cuff is torn, or there is tendinosis and tear within the tendon called as intratendinous tear, or there is a tear from the articular side, the bursal surface being normal. Most of these are managed conservatively. Coming to the complete rotator cuff tears, they are broadly divided into posterior superior, as the name suggested, posterior supraspinatus and infraspinatus, anterior superior, which is anterior half of supraspinatus, and subscapularis. So let's talk about the subscapularis tear. Obviously, you diagnose them on the MRI. On the MRI, the first sign is on the left-hand side, you see a normal biceps in the groove. On the right-hand side, there's absence biceps in the groove. There's a subluxed biceps completely into the joint, and there's a tone subscapularis, which is retracted up to the level of the glenoid. On the sagittal oblique view, on the left side, you see the normal lesser tuberosity with the subscapularis attachment, and the affected side, you see the absence of the subscapularis. These are the images which on the MRI which tell you the presence of a subscapularis tear. Coming to the supraspinatus and the infraspinatus tear, you mainly look at the coronal images like you see in these various images. You see a complete retracted tear. Based on the degree of retraction, they are either going up to the level of the humeral head, or up to the level of the joint, or beyond the glenoid, based on which we call them as grade 1, grade 2, grade 3, and massive retracted tears. Now, it's very important on the MRI to look for the tangent sign. So this is the sagittal oblique image, T1 weighted image, on which you draw this line from the tip of the spine of the scapula towards the corcoid tip. If you see muscle belly above it, that's normal. When you see lack of muscle belly and there is a fatty substitution, it tells you there is muscle wasting and tells that the tear is chronic. More importantly, you need to look for fatty infiltration. The muscle has been replaced by fat, like in this case, there is more fat than muscle. It indicates a grade 4 type of fatty infiltration by Gutalier grading, which tells you this is an irreparable tear. Also, a subtle sign in patient who otherwise the muscle looks okay, like here, there is teres minor hypertrophy, which tells you that this pathology has been persisting for very long. It's an acute and chronic phenomenon, and you need to be careful about prognosticating repair for this tear. So that's what I wanted to show in the images. Coming to other cause for pain in the shoulder, that's the impingement syndrome, which is basically nothing but the cuff getting impinged between the glenoid and the acromion. It could be, or the cuff getting impinged on the acromial side or on the joint side. It could be divided as external or internal. When it's external impingement because of the acromion morphology, typically we see a source sign on the plain X-ray. So plain X-ray also tells you there is impingement. So that's like the eyebrow shadow, which you are seeing. That's the sclerotic shadow, called as a source sign. Now, immediately it's important to understand the acromial morphology. We all have understood how to take a scapular Y view. On the left-hand side, you see a flat acromion, that's type 1. Here we see a curved acromion, that's type 2. This is the more common variety. Rarely we see a hooked acromion. This is an uncommon variety, and these are the ones which are responsible for cuff impingement externally, causing bursal surface tears partially initially, and if the pathology persists, then leading to complete cuff tears. A variant in this is a keel acromion, which is a massive keel that is there. These are 100% associated with bursal surface tears, and 100% association is there with complete rotator cuff tears. And this is probably the only indication in our practices to do a acromioplasty primarily, even in the absence of a complete rotator cuff tear. Coming to the critical shoulder angle, this is a new concept. So not just the anterior acromion, according to Christian Gerber, the lateral acromion, the lateral downslope of the acromion is very important. So you draw a line from the inferior glenoid to the superior glenoid and from the inferior glenoid to the lateral border of the acromion. Higher the ankle, higher this angle, higher the case of lateral impingement and higher the chances of rotator cuff tear because of external impingement. So this is another important concept we need to understand. Coming to internal impingement. This is typically seen in throwers on the dominant side where there is restriction of internal rotation, like you see in this video. There is impingement of the cuff between the glenoid and the humeral head because of a tight posterior capsule. And this is the triad on MRI that you see. A partial articular surface rotator cuff supraspinatus tear. You see a posterior superior labral tear, and you see a subchondral cyst. Those are the three findings of internal impingement. Let us now come to the acromioclavicular joint, which is an important cause of pain, either because of instability or because of arthritis. We need to know how to get a Zanka view. A Zanka view is an AP view with 10-degree cephalad tilt of the X-ray beam. As you can see on top, that's the overlapping shadow which you see on an AP view, but on a Zanka view, you can appreciate the acromioclavicular joint profile very well. Rockwood classification, all of us are aware. Type 3, when there is displacement of the clavicle such that it is matching to the acromion, not completely displaced by 2 to 3 times. And type 5, when it is displaced completely, there is no contact with the superior border of the acromion. So that is the how a Zanka view will help to understand very well. In early cases of arthritis like here, an MRI will help. As you can see, you can just see subchondral cyst and some soft tissue edema. But obviously, in advanced osteoarthritis, a nice Zanka view will give you the findings of cirrhosis, joint space narrowing, osteophytes on the undersurface of the clavicle, and on the acromion. Coming to the third other source of pain, the long head of the biceps. All of us know the biceps has got a portion which is extraarticular in the intertubercular groove and an intraarticular portion which then connects to the supraglenoid tubercle. So problems either in the groove or in the intraarticular space can cause pain in the shoulder. Like here, there is a subluxed biceps in the tone subscapularis. The biceps is herniated there. This is a nice video of a patient who has suffered from bicep subluxation, and this is the ideal indication for another radiological investigation called as a dynamic ultrasound. You can see the subluxing biceps in the groove here. Because this is a dynamic phenomenon, the dynamic ultrasound, like you see here, will show the subluxation of the biceps. That's another important investigation we use in shoulder. Coming to shoulder instability, that's a dislocation case, anterior dislocation. So you'll see a Bankart lesion and a hillside lesion. So let's go through a quick images. Plain X-ray will help you in the presence of bony injuries like a glenoid injury and a tuberosity injury like this here. A true AP will show you the loss of the double contour sign. MRI typically will tell you about the Bankart lesion in the anterior inferior quadrant and the hillsides, depth, etc. and the measurements. What's more important, this is the classic image of a Bankart and a hillside lesion. What's more important to understand if there is any significant bone loss and whether it's an on-track, off-track morphology. So that's how our radiologists are reporting every case of anterior shoulder instability. And a CT is taken in every case because we need to know whether it's a bony procedure that needs to be done or a soft tissue procedure. So that's the on-fast view, which tells you there is significant bone loss and a bony procedure needs to be done. Quickly, we cover the posterior instability also. So there is a tear in the posterior inferior labrum. That's the posterior jerk test, and the appearance of the posterior labral tear on axial hinges on a sagittal image, and the reverse hillside lesion. These are various findings you see on the MRI. Coming to superior labral tears, that's a evidence of a type 3, type 4 labral tear where the biceps is involved. The MRI is the investigation of choice, which tells us about the superior labral tear. Sometimes they are associated with paralabral cysts, which compress upon the suprascapular nerve in the spinoglenoid notch, like you see here. Coming to the other cause of pain, that is a capsule in the synovium. Synovial osteochondromatosis is a classic example. MRI will give you the findings. Frozen shoulder, all of us, it's a day-to-day case that you see in the OPD. You see that there is loss of the normal signal. There is thickened anterior inferior joint capsule, and you will see rotator interval scarring. So these are the three findings that you will confirm frozen shoulder. You all are aware of arthritis sometimes affects the shoulder also. The plain X-ray will tell you joint space narrowing, osteophytes. Actually, we will show you posterior subluxation. CT scan again will show you posterior subluxation and the profile of the glenoid vault. So these are the investigations. Sometimes.
Okay, I'll have to ask Dr. Nagraj to stop here because we are shooting a little over time. I think we'll go for the next presentation. So next we have Dr. Satish Mutha. Satish,
Yeah, you start my video here.
Yeah, please do that.
Stop my video here. You have stopped my video.
Satish, I have no control on that.
Yeah, it says the host has stopped it.
Kshitij, Kshitij.
It's on.
Yeah.
It's on.
Okay.
Satish, just share your screen.
Am I seen and heard clearly?
Yeah.
Okay. Good morning, everybody. At the outset, let me thank Bombay Orthopedic Society for giving me this opportunity. And today I'm going to speak on ultrasound guided musculoskeletal injections, which few of y'all may be doing. But for those who aren't, I think it's a wonderful thing for you to add in your practice. Disclosures none, just that I love giving injections. Now,
Satish, can you make it play your presentation? It is still in the
play.
Yeah, play from the first slide so we see it full screen.
It's full screen on my computer.
Slideshow.
No, you go to slideshow. It is not slideshow here.
Yeah, it's slideshow from beginning. Yeah, fine now.
There is some lag in
there is some
Zoom, so give it some time.
I think you can keep on talking. It will happen.
Okay.
Please continue, Satish.
Yes. So we all use steroid injections in our day-to-day practice. There are clear-cut indications and it works very beautifully when given properly, and patients are really thankful when it works. But we all know that in certain situations it will not work, and sometimes it causes embarrassment for us. Now, local injection not working is not entirely because of the technique, could be many other things, but technique also plays an important role. Now, various studies have shown the efficacy of these blind intralesional injections between 60 to 80%. It is even poor in the shoulder because shoulder being a huge joint is difficult to identify the landmarks, and many studies have shown that 30% injections will miss your target in the shoulder. Now, because of this, over the last 2 decades, ultrasound has gained a lot of momentum in orthopedic practice, not only for injections but for diagnosis in many aspects. And as far as injections are concerned, ultrasound has really improved our efficacy of injections. Various studies in the last 2 decades have shown that efficacy improves significantly once you start using them. We all know, as Nagraj also pointed out, that USG is rapidly developing as a valuable tool in MSK injection outcomes. It's different from an MRI. It's not a tomogram like an MRI which gives you cuts, but it's a scan in continuity. And apart from improving your injection techniques, it really helps you to analyze the structure that you are injecting before you inject. So when you do an ultrasound before you inject, you are able to assess the structure that you're.
Dr. Satish, can I stop you?
Yes.
Your slides are not moving. So is it possible for you to stop share and start again?
Okay.
Like from the relevant slide, not from totally from the front or from the beginning, but stop share and then start again. You can resume from your slide that you were talking about.
Yeah, I did that again. Can you see it now?
Yeah. So can you go to the slide that you were on and you can go back speaking.
Yeah, this is the
Perfect.
slide.
Please go ahead.
Okay. So it helps us to assess the structure, the pathology, inflammation, tear. It tells you the dynamic study about the gliding of the tendon, the adhesions. And now that we are increasingly using more expensive injections like the PRP stem cells, we need to do something to improve our accuracy of injection. So ultrasound guided injections definitely improve our outcomes here. Another advantage is you can actually take a picture of your needle placement, so you can document that what you have done is proper, and then if it doesn't work, then you look for other things. It also helps you medically in certain situations, and most important, it appears savvy, so it appears more trendy and you can charge more. Now, technical aspects, you have to speak to your ultrasonologist. You will need a probe which is 5 to 15 megahertz transducer. They need to have a linear probe and a convex probe. A linear probe is for tissues which are up to 5 millimeter deep, and a convex probe is for deeper structures like the shoulder. You need to go to their center now because of the PCDNT rules. They cannot come over. So you need to establish a good rapport with them. You would just need a set of sterile gloves, mask. Instead of their jelly, you can use our sterile Lignox jelly quite efficiently. That even assures that you're using a sterile gel. Sterile disposable drapes and a needle which is 1.5 inch, generally 22 or 23 number. Now these are the various indications. I will restrict myself to the shoulder. Now, biceps tendinitis is one of the common things that we see in practice in these gymmers and heavy athletes. And in an obese patient, feeling the biceps tendon and giving an injection blindly can be really difficult and may not work. Now, here ultrasound helps you to perform a diagnostic evaluation of the tendon, see for any tear, synovitis, and then you can give an injection quite precisely. You can see this video here very nicely while injecting. You can see the greater and the lesser tuberosity, the groove in between, and the tendon lying in between. You can actually analyze whether there is an effusion, there is synovitis, any pathology around that. And this is in the another angle when you can see the tendon along the length. There is no tear, the tissue quality is good. And then you can gradually see the needle coming in. On the upper right hand corner, the needle comes in and you can inject it. You can take a picture of the fluid being injected there. That can even help you to document. Subacromial bursitis. As Hetal pointed out, shoulder is a Pandora boxes. There are so many pain generating factors, the bursa, the AC joint, the biceps tendon, and very often you would really not know where to inject. So patients with these milder pains where you don't want to do an MRI, ultrasound can help you evaluate the rotator cuff function. Against vis-a-vis an MRI, ultrasound will allow you dynamic evaluation and mobility of the cuff also. And in an acute calcific tendinitis setting, with the help of ultrasound, you can really precisely inject and give good pain relief. This you can see fluid, subacromial bursa. You can see the bursa nicely collected there in the area of the tendon, and you can precisely place your needle into that and get a good result. Same thing with rotator cuff tendinitis, mild pains, no tears. The pain does not respond to conservative treatment. You can precisely inject with the help of needle, as I will show you later. It is also very useful in post-operative cases because very often after surgery, 2 months, 3 months rotator cuff repair, patient continues to have pain, and an MRI does not give a very clear picture because of the titanium implants or whatsoever. Here, the ultrasound really helps you to see the continuity of your repair, the surrounding tissues, and you may even dare to inject a small amount of steroid, clear of your repair, and expect to get good pain relief. So you can see this. This is a view which the radiologist generally use it. It's known as a short axis view. It gives a very clear view of the humeral head cartilage, the supraspinatus tendon from the anterior to the posterior structure. This is the modified CRAS position, which gives a very good visualization of the entire rotator cuff. And here you can see the cuff. You can see the articular cartilage, the humeral, the greater tuberosity, and the biceps tendon. The supraspinatus. You can see how beautifully the needle is advancing towards the tendon. Now I have punctured the tendon here. If I was injecting it blindly, I wouldn't know, and inadvertently I would have injected there, sometimes causing a tear. So I withdraw my needle, I know my placement, and I can actually inject it in a safe place outside the tendon. Other indications in the shoulder where you can precisely inject with the help of ultrasound is the AC joint. Very often that arthritic pain is quite nagging. Glenohumeral arthritis. Of course, injection is not a treatment, but as a salvage or buying time, you may consider injecting a resistant frozen shoulder, as Mihir pointed out. Sometimes can respond very well to an intraarticular steroid injection. And post-repair pains, where you're sure your cuff is repaired well, you have a good dynamic evaluation of the tendon, and you may inject.
Satish, finish off in a minute.
Thanks. I'm done. Thanks. Yeah. So
I think you're done. This is for the ankle.
So this covers most of the indications in shoulder, and all I want to say is that we all are injecting, but try exploring this option that is beautiful and will really improve your results. Thank you.
Thank you, Satish. I will call upon Dr. Rajesh Gandhi to share his screen. Satish, you can stop sharing your screen now.
Yeah.
Good morning, everybody.
Good morning, Rajesh bhai. You're going to talk about manipulation of the shoulder under anesthesia.
Yes, I'll start the...
Share the screen.
Good morning, everybody. I thank Bombay Orthopaedics Society for giving me this opportunity to present the manipulation technique and the pros and cons. Now, historically, the closed manipulation has been often been recommended as a next step after the failure of the non-operative treatment in a patient with the shoulder. Now, what are the type of anesthesias one can give? One is interscalene block, you can give a suprascapular block or you can do it under general anesthesia. Well, I always prefer under GA because it gives a complete muscular relaxation and it facilitates and produces the minimizes the risk of the fractures. Because and how to do it, I guess everybody knows, all orthopedists knows, they've done it, but with still I'll describe some method in a brief. Now always compare the normal side, which is extremely important. Now what is important is that you stabilize the scapula and the clavicle. The lever arm used for a manipulation should be a short lever arm so that chances of fracture development or chances of tearing the tissues are lesser. Manipulate in all the directions with a short jerky movements to break the adhesions. How do you know that things have moved? This is just we are comparing initially. Now this is the way the manipulation has to be done. The lever arm should be a very short lever arm. It should be very close to the joint. At the end of it, please see that you have achieved all the movements. Now, a good prognostic sign is the production of the crepitus, followed by the immediate full range of movements. How do you ascertain that? Once you ascertain that, keep the hand up, abducted and externally rotated and above the neck, that head. That is the way you can come out. Now, question arises whether to give steroids following the manipulation or not, whether to give triamcinolone or methylprednisolone. If to give, how much to give? Can it be repeated? These are the questions we need to answer once we have done the manipulation. Now, when the manipulation is done, treatment using steroid injections with distension as an outpatient treatment is recommended for the primary frozen shoulder or a periarthritis. Now, there are some reports which does mention that it is helpful. Now, whether to use a triamcinolone or a methylprednisolone. One study where both the triamcinolone acetate and methylprednisolone were given, they were found equally effective in primary frozen shoulder. Now, triamcinolone acetonide significantly improves in diabetic frozen shoulder in comparison to methylprednisolone acetate, 69% versus 39%. Now, what is the dosage one would like to give? 40 milligrams of triamcinolone or 40 milligrams of methylprednisolone can be given. It should be mixed with ropivacaine and given in the extracapsular region. Now, this particular study shows that there were no significant statistical difference between the high and low dose corticosteroid groups, indicating preference for the use of a low dose in the initial phase. Now, post-manipulation protocol is very simple. Immediate intensive mobilization has to be done. Narcotic analgesics have to be given to the patient so that they can do the exercise better. Now, status in the diabetics is very clear that the stiff shoulders associated with insulin-dependent diabetes does not respond well to the manipulation under anesthesia. Often, they refreeze within 3 weeks. Now, the outcome of the manipulation under general anesthesia following a frozen shoulder with diabetes mellitus, this prospective studies of 10 years adds to the existing literature by quantifying the success rate after single MUA in diabetic patients. The patient satisfaction was only 64% compared to the normal individual non-diabetics where the patient satisfaction was about 80 to 83%. The failure rate is about 36%. Subsequent repeat MUA after failure of the procedure was successful in 85%. Now, complications which one can encounter is the fracture of the proximal humerus, muscle tears, recurrent stiffness of the shoulder joint. Nerve palsy has been reported in few cases where the brachial plexus palsy was seen following a post-irradiation fibrosis. So one has to be extremely careful if patient is on a chemotherapy and post-irradiation fibrosis has taken place. Give a second thought. Do not try to be too proactive. Now, the patient with a poor outcome or a recurrent symptoms of a frozen shoulder should be offered further MUA with expectation of a good outcome and the complication rates are slightly increased. But what is the flow chart? When you do the MUA, if the clinical success is good, very good, be happy. If the persistent or recurrent frozen shoulder, well, should you do redo MUA or not? One has to take call on individual cases. Now the new symptoms have uncovered. Investigate, and then treat accordingly. The take-home message is MUA is a good procedure in very selected cases. MUA with the steroid outcome is same or a little better. Outcome in insulin-dependent diabetics is not very encouraging. Thank you very much.
Thank you, Dr. Rajesh. Stick around for the questions, or you can go to YouTube chat and answer the questions there.
Sure.
I will ask you to stop sharing your screen. And Dr. Thakur, sir, you are next. Please share your screen. And Dr. Thakur is going to talk about OPD reduction of dislocated shoulders without anesthesia. Sir, you can start sharing your screen.
Yes, I am there.
Here, there is a question from the audience, and that is, what about stretching for pain relief?
Did not hear your question.
Pain relief. Why should stretching not be done? If you keep the shoulder immobile, there will be stiffness which will add to the pain. This is a vicious cycle. Stretching will in fact gradually reduce the pain, help to keep the range of motion better. So why not start stretching immediately?
So you have to understand, pain is because of inflammation, stretching is because of fibrosis or tightening of the capsule, and they are two completely different aspects, have to be managed differently. We know that inflammation increases if we do any kind of exercise. So when there is pain, we need to stop all the exercise so that there is rest. There is no excursion of the muscle or the glenohumeral joint. Get the inflammation less, get the redness away, let the pain come down. Stiffness can be very easily managed by stretching exercises.
Right. Thank you. The question for Dr. Rajesh Gandhi, sir. You are here. Dr. Rajesh Gandhi.
Yes, I am here, sir.
There is a question from the audience regarding the incidence of fractures during the manipulation of the shoulder.
I'm sorry, your audio was not clear. Can you repeat the question, please?
The incidence of fractures of the humeral neck while doing the manipulation, and if so, how do you manage that?
Yeah, well, as my last slide showed, that the problems arising out of that, if a new symptom arises, you have to treat accordingly. So if the pain has increased, obviously one would like to do the either MRI or the scan later on. And if it is showing any fracture, then it has to be treated appropriately. Now the incidence in the literature is about 3 to 4%. Different studies have shown different results. I guess that answers your question, sir.
Okay. Dr. Hetal, are you here? Right. Hetal is not answering. I'm going to direct his question to Dr. Nagraj. Nagraj, are you here? Dr. Mihir?
Yes, I am there. I'll take the question.
Yeah. Mihir, the question is that there is a lot of emphasis placed by Hetal on trying to identify the shoulder pathology, which is actually causing the acute shoulder pain. The question is, how does it really matter? You are still going to treat the patient with ice packs, with anti-inflammatory medications, with gentle stretching. So why should it matter?
Hi, I am here.
Try to diagnose.
Yes, I am there. I'll take the question. Okay, Hetal, you are taking that question.
There is a lot of emphasis placed by Hetal on trying to identify. Mihir, you are clearly heard. You take the question, please.
I am here, Gautam.
So Hetal, please answer the question.
Sorry,
how
what
does
was the
it
question?
make
I could not hear you.
In an acute shoulder pain?
Yes.
How does it really matter whether this pain is cuff pain or whether it is frozen shoulder? Because you are going to treat this patient with ice packs, NSAIDs, gentle stretching exercises, etc. And if it doesn't work, even a steroid injection. So why should you make this much of an effort?
I would say that I have in my clinical practice, in 1 year, if I am seeing say 50 to 60 calcifying tendinitis patient, I am injecting half of them. You mean to say in 2 years, last 2 years, I must have given one injection for calcifying tendinitis. You almost never need such injection. Second thing, when the patient comes with a pain of acute calcifying tendinitis, they are in tears. They won't answer. They'll ask you, doctor, what is it? What are you going to say? It's frozen shoulder? So that when someone else asks for X-ray and you go and do and find calcification, you will be considered a fool. For acute shoulder pain is never a frozen shoulder pain, and the whole treatment depends on it. A frozen shoulder has a restricted movements. It needs a good stretching physio exercise program, whereas a calcifying tendinitis is going to resolve in 5 days. 99% of the calcifying tendinitis is going to resolve in 5 days. I really, and if you do not diagnose correctly clinically, then you are going to give them wrong advice. So many patients of calcifying tendinitis, on second day, they are advised MRI by orthopedic surgeons, and by the time they come, they are already relieved of pain. So in an acute shoulder pain with a painful shoulder, you are putting that patient in an MRI tube for half an hour just because you are not being able to clinically diagnose it. It's absolutely mandatory that you identify these patients clinically. And I see a lot of these patients who come as a second opinion, and they are frightened. They are frightened. What's this, doctor? What is happening? This MRI is showing this. I am still not having really. So you need to clinically reassure the patient that this is the diagnosis. This is going to be the treatment, and you are going to get all right. And that works in most of the cases. I don't understand of logic of needling and all, because in my clinical practice, I almost have never done this. Rarely.
Right, Dr. Nikhil, we have understood your point. Thank you very much. I think all the other questions have been answered by the faculty on the YouTube chat. So we will go back to Dr. Harshad and request him to get Dr. Thakur online.
Yes, thank you, Gautam. Dr. Thakur, can you hear us? Can you come? Dr. Thakur, can you hear us?
Yeah, I can hear you.
You can start your presentation. Your screen is already shared.
Okay, thank you. Good morning, everybody. I'm going to talk to you about Cocker's painless reduction of dislocated shoulder, doing it right in your consulting room. So this method was introduced by Emil Kocher, and he described he got a Nobel Prize, and during his Nobel Prize biography, this method was mentioned there. He describes it in 5 steps. 5 steps are: bend the arm at the elbow, press it against the body, rotate outwards till a resistance is felt, lift the externally rotated upper arm in the sagittal plane, and lastly, turn inwards slowly. To recapitulate, here are the 5 steps. Bend the arm, press it against the body, rotate outwards, lift it externally rotated arm in the sagittal plane, and finally turn inwards. Nowhere it says that give traction. There is no mention of traction. You can double check it. So this eponyms, they go on step. He introduced this in 1870, and as we know, the eponyms stick. Kocher's method, everybody says yes, and when they come to describe it, they say gentle firm traction, or steady traction is applied, or traction to the flexed elbow. Kocher never ever mentioned a traction. So where did this traction come in? So there was no mention of traction. This was rediscovered by me in 1974. And this is what is the common saying. There is no mention of traction. In 1974, I bought this book and read through it. And in that, this original method by Kocher was described. And that put me thinking that let's try it without the traction. And when we started doing it, it was a big success. Later on, we published this in Bone and Joint Surgery in 1990. I think about 30 cases we did. Most of these cases were done at Cooper Hospital, where we are holding this symposium today. And Incidentally, this was the first paper in international journals from Cooper Hospital. Traction is detrimental. Traction further stretches the tight capsular band, which obstructs reduction. This is the tight band because of the dislocated shoulder, and when you give traction, it becomes taut and painful. It blocks the reduction. So traction creates the need for anesthesia and sedation. If one doesn't give traction, there is no pain and it can easily reduce it. Late reduction, about 7 days old dislocation I have reduced in a soldier. And a lady driver got stuck in the car because of the dislocated shoulder. She couldn't come out, so I had to go to the car and then reduce it in the parking lot. The last fancy one was in an actor's vanity. The success rate is 95% in acute dislocations. Here is a video which will show you how it is done. This is an anterior shoulder dislocation. You can see it is subcoracoid. And continuous talking to the patient and reassuring that his pain is not going to increase is important. Unless we do that, it will not be done. They will not cooperate with you. As you can see, I now gently fully externally rotated and pushed it towards the chest wall as much as possible. This is a video of the externally rotated arm. I'm going to gently lift it up. Press it against the body and now lift it in the sagittal plane and the externally rotated arm. It goes without any pain. Look at the patient's face. There is not an iota of pain on his face. It goes very gently, very smoothly. Some patients, because of pain, refuse to lie down. So we can do that even in sitting position. You got to constantly reassure the patient that the pain is not going to increase. In fact, it will go down in a second. Continuous talking is the trick. Otherwise, patients do not cooperate. I ask them to externally rotate themselves and I only assist them. Once they get the hang of it, it is all done very easily. It needs a lot of reassurance and then it suddenly goes in. There we are. It is so gentle, no need to push or pull. Explaining a manual and gaining his confidence is really important. So as you see, it is very easy. If one follows the original method, there is no need for traction and that does the trick. It is always possible to reduce an acute dislocation in your consulting room. Thank you for your attention.
Thank you, Dr. Thakur.
Yeah.
We have finished the question answer sessions on shoulder. I would request you to look at the YouTube chat. If there are any questions, you can answer them directly.
Okay.
This concludes the shoulder sessions, folks. We are now going on to the spine session. 1 hour. The next 1 hour will be talking on spinal problems and how to manage a patient coming to your OPD with back problem. Dr. Thakur, I would request you to stop sharing your screen now. Dr. Thakur, sir, stop sharing your screen. And Gautam, you can start sharing. Dr. Gautam Zaveri is our first speaker. He's going to talk on diagnosis and identification of cause of back pain in an individual.
Can you see my screen?
Yes, Gautam, go ahead.
Good morning. Why low back pain? Why are we talking today about acute low back pain? It is one of the most common benign conditions in medicine. It is the most common disabling illness in patients less than age 45. 80% of the human population, that is at least 4 out of 5 of you, will have at least one significant low back pain episode during your life. 80% will go on to recover well within 6 weeks, but about 10% to 12% will develop what is called as chronic low back pain. When a person has acute low back pain, there is a lot of panic. He approaches a number of different practitioners. Family members give their advice. You go to a masseur, acupuncture, acupressure, physiotherapist, chiropractor, and sometimes he goes and approaches an orthopedic surgeon. A variety of treatment remedies are given. Sometimes like this Martian belt over here, some manipulation in one direction or the other. Rich people buy expensive tables and other therapies which will give them relief of pain.
Just be ready.
Of course, we as surgeons tend to give the patient traction either downwards, upwards, and in every possible direction. The remedy, of course, is often worse than the disease. When we were in med school and as postgraduate orthopedics, low back pain was relegated to the junior most houseman. None of the seniors wanted to see this patient. The junior houseman saw the patient, gave him APC drugs and kicked him off to physiotherapy, hoping never to see the patient again. And yet, if you see a clinical practice, 3 out of 5 of you will be, so 3 out of 10 patients you see in your OPD are either low back pain or neck pain patients. So I'm going to share with you my experience of treating back pain patients with over the last 25 years, as well as what is the current evidence on this subject. Basically, when you talk about acute low back pain, you are talking about a pain which is of less than 4 weeks duration and usually is moderate to severe in intensity. The first thing you must ensure and reassure the patient by telling them that back pain is usually not due to anything serious and that most conditions are simple and can be treated easily. In fact, 85 to 90% of back pain is non-specific back pain, which comes from muscle sprains, joint sprains, some edema in the joint, some disc degeneration, and sometimes some facetal locking. Less than 10 to 15% of patients have any major cause. Among them include inflammatory causes like rheumatoid arthritis, ankylosing spondylitis, metabolic causes, which all of us are now becoming more and more aware of, such as osteoporosis, osteomalacia, infections, trauma, neoplastic, and don't forget the non-spinal causes. A urinary tract infection, a pelvic inflammatory disease can present as back pain. A kidney stone can present as back pain. Cholecystitis can present as back pain. So does gastritis. So don't forget to examine the Pandora's box, that is the abdomen. Well, in children, back pain is extremely rare. However, if a child complains of persistent back pain, you must be very, very careful because they can often have more serious problems such as an infection or a tumor underneath. In the adolescent years, the most common cause of back pain is a poor posture. Along with that, sports-related injuries may result in a break in the bone somewhere, which can cause back pain. In the typical young adult, Back pain comes because of wear and tear of the disc. If you see, the normal disc is white in color on MRI T2 weighted images. This disc is black in color, indicates that it is desiccated and degenerate, and occasionally can cause low back pain. The other cause of back and leg pain is what we all commonly call as acute PID, which is a prolapse intervertebral disc. And primarily, though there may be back pain, the primary pain is in the leg. In the elderly, there are two common causes of back pain. One, as we grow older, we develop arthritis in joints of the knees and etc. Similarly, the joints in the back, such as the facet joints, can become arthritic, develop synovitis or effusions, and these are painful. Secondary to the arthritis and hypertrophy degeneration that you undergo, you develop a spinal stenosis, which can cause back and more likely leg pain. And of course, osteoporosis and osteoporotic related fractures are cause of back pain. What is the rational approach? We know that sinister causes such as infections, tumors, and fractures constitute less than 5% of cases of low back pain. 80 to 90% of these patients can be identified early by what is described as the red flags. The red flags are that if a patient is having back pain for the first time in his life and he or she is under the age of 20 or over the age of 60, then this is a red flag. Along with back pain, patient is having severe or progressive neurologic deficit, night pain, rest pain, thoracic pain, which is non-mechanical pain, or the patient comes with a structural deformity secondary to the pain. The patient has fever, weight loss, malaise, loss of appetite, or a past history of cancer, steroid intake, HIV, or a significant trauma. All these patients constitute the red flag, which can indicate a sinister underlying problem. The other set of complaints which can indicate a very serious problem is if the back pain is associated with bladder or bowel disturbances, reduced sensations in the perineum called as saddle anesthesia or hyposthesia, pain, tingling or numbness and weakness in both the legs, and gait disturbances. The step 2 in this patient is, we know that if it is not the 5% sinister patients, the remaining 95% of patients are what we call as non-specific low back pain, mechanical back pain, or degenerative back pain. In these patients, even if you try, a specific pathology can be identified in less than 20% of the cases. So in these cases, rather than to identify a specific cause, we treat the patient based on a clinical presentation and a pattern of pain, rather than trying to do huge investigations or planning more, because for non-operative treatment, the specific pathological diagnosis does not seem to matter. Well, I divide patterns of back pain, mechanical back pain, into 5 patterns. The first pattern is a pattern where the patient complains of back pain, occasionally some buttock or diffuse leg pain. This pain is worse when the patient bends forwards and is better when he extends the spine. This back pain, which is a predominant back pain and not a predominant leg pain, is slow in onset. If you ask the patient may not be able to tell you when it started. It's for a very long time and it stays with the patient for a long duration. Typically, this is because of wear and tear of the disc, a condition called as disc degeneration. Pattern 2 is a pattern, again, back pain, either anterior or posterior thigh pain can be accompanying, but it's predominantly back pain. It is worse on extension, better when you flex the spine or bend forwards. It is of sudden onset. Patient says, I was picking up a bottle of water, a bucket of water, and I suddenly got pain. And it stays for a short duration, matter of days to weeks, the patient is better. Here you think of facet joint pathology. The third pattern is a pattern all of us are well aware of. Along with the back pain, now the patient gets pain which is radiating down one of the nerve root distributions. This is radicular leg pain primarily, which is worse when you flex the spine, better on extension of the spine. On examination, signs of nerve root involvement such as tension signs, SLR, or femoral stretch test may be positive. Here, we think of a lumbar disc herniation. The fourth pattern of pain is a pain which occurs typically in elderly age group, above 50 or 60 years of age, typically more commonly in women. Patients complain of intermittent buttock pain, thigh pain, calf pain, may not be pain, may just be heaviness, may be radicular in one of the leg distributions, or maybe just tingling or numbness, which increases when the patient stands and walks, but is relieved with sitting and bending forwards. Signs of neurologic deficit is usually not present. Back pain may or may not be there. Here one thinks of lumbar canal stenosis. The fifth pattern is an pattern of unremitting pain. There is abnormal behavioral pattern. The patient has seen many different doctors, has a whole ward of investigations. He comes with a whole big file of reports. Every time you see the patient, the location of the patient varies, the symptoms expand. The pain has been present without a clear supporting diagnosis in many cases. There are sleep disturbances, loss of libido, family problems, etc. Here one thinks of what is called as illness behavior, indicating that this may actually be a functional problem. Gordon Waddell from the US described some non-organic physical signs to try and diagnose patients who had these kind of functional problems. If when you touch the patient, superficial tenderness, patient starts screaming with pain, doctor, what have you done? Or there is non-anatomic tenderness or axial tenderness, when you press on the head, patient complains of back pain, that is usually non-organic. Axial loading or simulated rotations causing pain. Distraction, if a sitting straight leg raise is negative, whereas a supine one is positive, then this goes more in favor of a functional problem. Regional, rather than having a specific radicular weakness or sensory loss, patient has a more regional, diffuse, unexplainable regional weakness or sensory loss, and overreaction. Every time the patient is very vocacious, he keeps on talking, or there is a lot of tears going on, then you must always think of a functional cause of low back pain. Now, going back to our approach, if there are positive red flags, which we mentioned, then there is no question, you need to investigate this person as early as possible. If there are signs of acute cauda equina, get an MRI done and refer him as soon as possible to a spine specialist. Or if there is a disc or something, operate on this patient. Otherwise, if there are positive red flags, you investigate early and then treat appropriately based on the diagnosis. However, if it is mechanical back pain where there are no red flags, the treatment is primarily non-operative. In these patients, getting investigations in the form of MRI has not been proven to be very useful, because if there is no acute low back pain with red flags, the chances that MRI will come up with something significant is less than 1%. So what is the goal of your non-operative treatment? The goal is to break the pain cycle. When there is back pain, the patient feels painful and he does not move. When he stops moving, it causes stiffness of joints, it causes stiffness and weakness of muscles, which in turn causes further back pain. In some way, we need to break this pain cycle, and we break this cycle by giving medications orally or injections into the facet joints or epidural injections to relieve the pain. And along with that, we start rehabilitation with exercises in order to help relieve the pain and break the pain cycle. What does the non-operative treatment of low back pain consist of? There is a short period of rest. I like to give local heat, but a lot of practitioners give shortwave diathermy, IFT, to which I have no quarrel. After that come medications, exercises, steroid injections, tractions, and belts. Let's explore each one of them individually. You must remember that bed rest is bad for the back. The caveat I use, and I always enforce it on my patient, is use your back or lose your back. Bed rest in back pain patients is maximum for about 3 to 5 days. Even within that period, in my practice, activity is started as tolerated, is started immediately. Even exercises within limits of pain and under the supervision of our doctors, of yourself, is started immediately. What about medications? There are a lot of medications which can be given. Anti-inflammatories, are they helpful? Yes, there are many studies which have shown that NSAIDs are extremely helpful. They reduce the inflammation, which is the primary cause of pain. However, the problem with anti-inflammatories is, of course, we are worried about their side effects, and therefore one needs to combine them with analgesics or neuropathic agents like gabapentin. Giving just analgesics like tramadol or gabapentin without reducing the inflammation is just trying to kill the pain without trying to treat the basic pathology. The third group of drugs which are given are muscle relaxants. I put to you, my audience, that if a patient has appendicitis and muscle guarding, will you give the patient antispasmodics to relieve the pain, or will you treat the inflammation of the appendix or an infection of the appendix? The same is true in the back. Muscle spasm is secondary to the inflammation. So you need to give anti-inflammatories rather than trying to put the patient solely on muscle relaxants. I often see a lot of orthopedic surgeons prescribe a lot of muscle relaxants, and I find no role for them in my practice. Chymotrypsin, trypsin, and flogenzyme, all these drugs are being used to reduce the inflammation, but there is no scientific evidence to support their use. Steroids have been used, especially by senior practitioners, short courses to help pain. They are not only dangerous, but their use is questionable. The most important thing is exercises. Exercises relieve pain by releasing endorphins. They prepare the patient for function and permit early return to activities of daily living. What type of exercises should be given? Should it be flexion, extension, yoga? The answer is it is according to the needs of an individual patient. McKenzie directional exercises, which means that if patient has flexion pain, prefer extension exercises, and if the patient has extension pain, give flexion exercises, is a simple way of starting off and relieving the pain. You must remember that a failure of a non-operative passive treatment, which means bed rest and medications only, should not be taken as a failure of non-operative treatment. When should you start these exercises? I start exercises on day one itself within limits of pain, whatever the patient can do. And in the primary stage, it is only gentle, active stretching exercises rather than any strengthening program. What about the role of injections, corticosteroids? Now, corticosteroids reduce inflammation. In fact, the best anti-inflammatory agent known to us are corticosteroids. And they are given because they relieve the pain. It does not cure the underlying pathology. All we are trying to do is break the pain cycle. You are telling the patient, yes, your pain will get better in 6 weeks. Patient says, doctor, how will I tolerate the pain for 6 weeks? In these cases, the pain cycle can be broken by giving an injection of steroid. If it is purely back pain, you can think about, if you are worried about a facet joint diffusion, you can think about giving a facet joint injection. If it is radicular leg pain, an epidural injection, either given interlaminar through a caudal route or transforaminally, is the best way to go. Ideally, an MRI must always be done before injecting the patient so that you can rule out any other pathology as well as plan your injection properly. Return to work. When can you allow the patient to return to work?
Gautam, you have another 2 minutes to finish.
Yes. If it is purely back pain pattern 1 and 2, I authorize the patients to return to work when they can, where they are comfortable. I do not force them to do so. In acute leg pain, which is within less than 4 weeks of leg pain, if they are still in severe pain, then return to work is contraindicated. So the rational approach is, if it is acute mechanical low back pain, non-operative treatment for 6 weeks. If there is no relief, then you try now to investigate and identify the pain generator. The investigations consist of X-ray, static and dynamic, MRI scans. There are also some provocative tests which can be done, but they have a higher rate of false positive, like facet joint blocks, nerve root blocks and discogram. Psychological assessment of the patient is important. It is more important to know what sort of a patient has the disease than to know what disease the patient has. Role of MRI scan. MRI scan is a highly sensitive investigation. It shows you a number of things which may or may not be the cause of pain. Things like vacuum sign, high intensity zone in the posterior annulus, end plate changes have all been described, but they have not been consistently shown to be the source of pain. And therefore, it is known that in patients without red flags, an early MRI has not resulted in better outcomes than conservative treatment. MRI is extremely sensitive, high incidence of abnormal findings in asymptomatic patients. So MRI must not be used as a tool to seek and find. Once you have identified a pathology, to confirm it in failure of treatment, you can use it. At the end of this, if no clear pathology is identified, treat the patient non-operatively. Just because patient is consistently complaining of back pain, don't feel obligated to offer an operation. Back dominant pain pattern 1 and 2, the natural history is benign. There is intermittent pain and recurrences are the rule, and there are more elements at work than mechanical factors alone. On the other hand, if a clear pathology is identified, then treatment in the form of surgery can be offered. So to conclude, the decision is more important than the incision. The natural history of mechanical back pain is mainly benign. Treatment is primarily non-operative. If there is leg pain, dominant pain, non-responsive to non-operative treatment, proven compression of the nerve, consider surgery. For back dominant pain in the long term, based on current evidence, surgery cannot be considered to be more effective than any other options in reducing your low back pain. Thank you very much.
Thank you, Gautam. I think you should directly go to the YouTube chat and see if there are any questions for you. In the meanwhile, I will invite Dr. Mihir Bapat to start his presentation on management of and diagnosis of neck pain.
Is my sorry?
Yeah, but go to the first slide. You're not on the first.
Can you see my presentation here?
Yes. We can see your presentation. Yeah, you're audible. Go ahead.
Yeah. So thank you, Harshad and BOS, for inviting me here. I think Gautam has covered almost all aspects of pain arising from the neck or the back. So when we look at neck pain, we have to demarcate pain as pain originating from the structures of the neck, referred pain to the neck, and psychosocial aspects of neck pain. Okay, so these are three parts of neck pain. Most of the pains, like Gautam said, in the back as well as the neck are benign. They arise from the muscles, the joints, and the discs, and they have to be treated conservatively. And you look for your the red flag signs for radiculopathy, myelopathy, and for certain signs which will herald a much ominous pathology. So when you look at all the patients that arrive to you with neck pain, most of these patients have some interference in their daily activities because of intermittent pain. These form the bulk of your patients. The other patients have repeated episodes of spasms which require rest breaks. These form a substantial group of your patients. Whereas the patients who actually require a surgical treatment, that is with radicular or myelopathic signs, are very few, that is less than 5%. So whenever you treat a patient of neck pain, an acute neck pain, it has to be either for a neck sprain, a postural neck pain, or a repetitive neck pain because of poor posture. So when you look at the problem statement of these patients, you have to understand that most of the patients in the villages have a different set of issues, whereas the people in the cities have a different set of issues. 80% of the people who sit on computers for more than 6 hours in a day often complain of a tired neck. So that's the beginning of a neck pain. So when you assess clinically what is pain, it is the duration of pain, whether it is the first episode, whether it is a repetitive frequent episode, whether it is an infrequent episode, or whether it is a chronic episode. The frequency of pain is very important. as is the character, the distribution pattern, and the clinical signs, which should be evaluated in details. So as Gautam pointed out, so whenever you have an acute spasm, you just look at what is causing the spasm and you treat that spasm. Whenever you have frequent repetitive episodes, you look at the posture, you look at the endurance and focus on that. Whenever you have chronic neck pain more than 6 weeks, then look for your clinical signs, look for your red flags and start treating them. So whenever you have an acute neck spasm, you have to understand that most of these patients learn to control their pain and may not always exaggerate the symptoms. And that is why an high index of suspicion should be maintained. And if these patients tend to become chronic, learn to investigate these patients. So whenever you understand your degenerative process, it is often a flexion loading. All our activities are in flexion. They are never in extension. So the first pathology always impacts the disc. And whenever the disc goes into an overloading phenomenon, the muscles go into spasm, and that is often in flexion. Over a period of time, your facets become arthritic and you start drooping. So the attitude of spasm is always flexion plus or minus torticollis, which proceeds to a fixed kind of a stooping. Arshad, I'm losing my images. I can't see my images on the left-hand side.
No, I think you're here. I can see you. You can just go ahead. I can see postural paresthesia common, repetitive.
No, but there's an image next to it.
Can you so that must be a problem with your presentation. You can just go ahead with it.
Okay. So most of these patients complain of postural paresthesias. That means that in certain attitudes of flexion or extension, they complain of tingling, numbness in the hands. These can be repetitive. They can be often transient and can often happen in the mornings. Now, this does not mean that the patient is developing a radiculomyelopathy. It is just a protective spasm and needs to be treated conservatively. Now, when the symptoms start becoming chronic, that means over a period of time, the neck starts remaining in flexion and the weight of the head exerts a minimum force of almost 7 kilos on your neck. And this creates a kind of an overloading stress on your muscles, putting these muscles into a state of spasm, followed by stiffness, followed by contractures. So these, Arshad, I won't be able to explain because my images are not getting displayed.
I don't know. It is not a problem with Zoom. It is a problem with the presentation. I think.
No, but
otherwise
this
you would be able to see.
I have reviewed at least 7 times. I could see my images.
So,
Only when I went on to Zoom.
So
only when I went on to Zoom.
What I would suggest is we can interrupt your presentation here now, and then you can check it up. In the meanwhile, we'll go ahead and then take your presentation after Nikhil has started it. Is that okay with you?
Yeah, because these words don't mean any meaning without my slides. They are explanatory to my figures.
Can you see it on your presentation?
Yes, I can see them, but it's very vague. Okay, it's a problem with Zoom. It has never happened before.
Yeah, what I would suggest is we'll interrupt your presentation right now. I will carry on with the next talk, and in the meanwhile, you just try and sort it out at your end. If there is another issue, we can take it, or if you have another presentation, you can put that up. Another copy of the presentation.
You want me to stop, or what is it?
Yeah, I mean, I can't solve that image problem from here right now. Okay. You can stop sharing, and then if you reshare, probably it will come up again.
Okay.
Okay, so in the meanwhile, what I will do is, if once Mihir, you can stop sharing the screen.
Yeah, okay.
Yeah. So Mihir will solve this technical problem. In the meanwhile, let me continue with exercises which we would use to treat back pain. I will start my presentation. All right, if you all can see and hear, I'll go ahead.
Yes, Harshad, please go ahead.
Okay, thank you. So as Mihir and Gautam were saying that exercises form the basis of treatment or conservative treatment for your back pain, I'm going to focus my talk on practical ways or practical exercises which you can advise your patient to do in the OPD It will make your and the patient's job a little easier and allow him to get back on the pathway to recovery faster. So Gautam has mentioned this, that exercises are of two types. One involves the stretching of the exercises, and the second involves actual muscle strengthening. Now, if you remember your physiology, the power or the function of the muscle depends on its length. The longer the muscle, the more innate strength it has. So stretching, which is a good exercise, can be done actively or passively, increases the resting tone of the muscle. So it provides strength to the muscle just by stretching the muscle to its original or more than its original length. The second set of exercises involves muscle strengthening. In muscle strengthening, you work the muscle against resistance, either using weights or using resistant bands or rubber bands. And this increases the muscle bulk. So it increases the muscle endurance. So simple stretching exercises are the ones which we would focus on. If you want to actually strengthen the muscle and hypertrophy it, patient would need to visit a proper physical therapist. For sake of convenience, we divide spinal exercises into those that involve flexion, extension, and those which strengthen the core muscle. However, you have to realize that this distinction is artificial. When you actually do the exercises, you're strengthening all these muscles, and the exercises are compound exercises. So when do you start exercises? Dr. Gautam said he starts exercises immediately, and the exercises are those of stretching. I personally feel that you should wait till the patient is 70 to 80% better after you've given him bed rest or medications to relieve his inflammation and pain. This, of course, needs to be individualized. In an otherwise active, young, and athletic patient who is motivated, you can start only stretching exercises at an earlier stage when the patient is still having some pain. But again, the exercises are limited by his pain. So don't go beyond the limit of pain which the patient has. Which condition do you advise which exercise? This question again comes into your mind when you advise exercise. But first thing you have to remember is that all patients require all types of exercises. So flexion, extension, and core exercises all need to be done. However, you can focus on one type of exercise for a particular given condition. Say, for example, if the patient is suspected to have lumbar canal stenosis, you should focus more on flexion rather than on extension, so as to increase the canal diameter to a certain extent and relieve the patient of pain. In disc herniation, it's the other way around. You focus more on the extensors and less on the flexors. Also, the pain the movement which causes the pain also dictates what kind of exercises you should do. If the flexion is more painful, then you focus on extensions and the other way around. So these are simple flexion exercises. Patient lying down supine and does pelvic tilts. Lying down supine, doing knee to chest, you can use a single knee or both knees. Patient may or may not use the arm depending on his innate muscle strength. Then the proximal muscles or the proximal flexors can be strengthened by doing half sit-ups. Extension position in prone, patient can do upper body extension either without the support of arm or use the arm supports to get his back in extension. Of course, not all patients having a stiff spine or patients having degenerative spine, not all of them can do these exercises. The other extension exercise is hip extension, keeping the knee straight. This strengthens the hip extensors as well as the lower lumbar extensors of the spine. What are the core muscles? The core muscles are a group of muscles which give innate strength to the spine in flexion and extension. The main core muscles are the transversus abdominis, the multifidus, the abdominal diaphragm, and the pelvic floor muscle or the pelvic diaphragm. The additional muscles like internal and external oblique, the gluteus medius minimus, quadratus lumborum, and the psoas also form a part of the core muscles. Core muscle strength is important to keep the spine erect. So core muscles can be strengthened by pelvic exercises, which are initially pelvic raises. You can do this cat and camel. You can do Superman extensions where both the upper as well as the lower limbs are extended simultaneously or alternatively. And then you can do leg raises, again a good core strengthening exercise. And finally, the best core strengthening exercise is the plank exercise. If you can do this, this will really help in strengthening your core muscles. Gautam talked about McKenzie method. McKenzie method was developed in 1981 from a therapist in New Zealand. So what it aims to do is to kind of reduce the pain and centralize the symptoms. And McKenzie is a pain directional exercise. If the patient is more painful on flexion, McKenzie focuses on extension exercises. And is it effective? Yes, there is enough high quality evidence to support that the McKenzie method is superior to any other method in relieving pain in patients having chronic low back pain. However, McKenzie is a specialized method and there need to be a trained physiotherapist, or you need to train yourself, or you need to educate yourself on how exactly to use this method for maximum benefit. So what do I advise my patients? So when patients come to me with back pain and I have ruled out major pathological conditions, all the red flags have been eliminated, and I know that this patient is going to fall into a category where he's going to get relief with exercises, I give him the following regimen. First, in the supine position, I start from distal to proximal exercises. So I ask patient to do leg raises, followed by knee to chest, followed by pelvic raises and half sit-ups. So if you look at this, the exercise start from the ankle to the knee, to the hip and to the shoulder. So it is easier for me to explain to the patient and easier for patient to remember also. Similarly, when I do extension exercises, I keep the patient prone and start from top to bottom. So I start with upper body raise and then hip extensions. And then depending on whether the patient is good enough or his muscle tone is good enough, I can ask him to do the Superman exercises, the cat and camel exercises and the planks. So this video will tell us how I go in the sequence. This to allow the patient to do straight leg raises. Keep his hand below his buttock and then do straight leg raises. 45 degrees, come down, don't touch the ground and come back up. There are 3 repetitions you can do that. This is the first exercise which helps to develop the flexor as well as the core of it. Second exercise, bend both knees and take knees to stop. This is to be done till your pelvis tilts and lifts up from the floor. This is the second exercise, again for the core and the abdominal flexion. Third exercise is the same position, lift up the hips and go as high as you can. Up down again and lift it back. So this is again for the core. Fourth exercise in the supine position is half sit-ups. Put the hand on the stomach and ask the patient to do just half sit-ups. Just so much that the shoulder comes off the leg. So these are 4 exercises supine position. For exercising extension, you should step up to a position. First exercise, lift the upper part of the body, up and down. Patient can do it with arm support or without arm support, as much as what is comfortable. This is the first one. Second is hip extension. Keep the knees straight, one leg at a time. Extend it back from the hip. 3 one leg, and then 3 on the other. Next exercise is that of Superman position. To allow extension of the upper arm as well as the foot. 3 repetitions of that. After this, you can go for the cat and camel. If the elbows extended, push the spine down. And finally, you end up doing the planks. Planks is a good exercise for the core, but not for. So that is how I advise my patients to start from the supine position, start from legs and go up to the shoulder, and in the prone position, start from the top and go down to the bottom. So most patients ask me, when should I do the exercises? I don't have time. I have to do so much of housework. So my best time for what I advise my patients is to when you wake up in the morning, before getting out of the bed, you start these exercises. And second time you do during the day.
We have to stop you now. You have overshot the time by about 5 minutes. So can we conclude the session?
You want me to stop here?
Yes, please.
All right.
Yeah, next.
So next session, I think Nikhil is going to be there. Nikhil, you can share your presentation.
Yeah. Okay, is it audible? Seen?
Yes.
Okay, and I'm audible?
Yeah, you are audible. Go ahead.
So thank you to BOS and Dr. Sharan sir and Dr. Argekar sir and Dr. Zaveri sir. So my today's talk is about root block in OPD practice. So as Gautam sir had taken up the discussion about back pain management. So root blocks are basically a pain management treatment that we give. It is done as an outpatient, and I'll be specifically talking about selective nerve root blocks. So what is it exactly? It is basically an injection of a local anesthetic mixed with a steroid. It has to be given under an X-ray guidance around the area where the nerve root exits the spinal cord. This is a very basic and simple definition of what is a selective nerve root block. There is a lot of literatures about this. The one which I have found most important if you want to convince your patients is the one done by Ryu et al., where they have seen that there is almost a 70% improvement in symptoms and where the patient can avoid a surgery for up to even a 1 to 2 year follow-up. Now, there are various different kinds of blocks apart from the selective nerve root blocks. We have the epidural blocks, the transforaminal root blocks, the facet blocks, and the others, as is shown in the pictorial. Just for a brief indications of each, epidural block, I give it basically when there is a claudication type of pain. So mainly for us lumbar canal stenosis cases. There is no one leg side pain. We have a bilateral leg pain or bilateral pain in the thighs. The selective nerve root block, which I give, is indicated for basically disc prolapses. Mainly I give it for the lumbar disc prolapse. You can give it for even cervical disc, some cases, where you have a patient with a radicular pain. Patient should have minimal of claudication symptoms. The facet blocks, I give it whenever indicated along with nerve root blocks, but very seldom I give it alone. It's indicated for lower back pain only, where you don't have a spreading type of pain, more of a localized pain, and where the tender points are palpable. It's not more of a diffuse pain. So about the selective nerve root blocks, the main indications for the SNRB are it should have a unilateral lower limb pain. Patient should have tried some conservative management, whatever. He should have taken either rest, should have tried some physiotherapy, taken some pain medications, gabapentins, pre-gabapentins. Ideally, I give it at least 1 to 2 months of duration of conservative treatment where the patient has actively tried it. Either he has been in touch with me or has been with some good orthopedic surgeon who has taken this, advises conservative treatment. Sometimes for a recurrent disc prolapse also you can, in this indications there. Absolute contraindications, as Gautam sir had said this thing, for Cauda-Equina syndrome, neural deficits, strict no-no. I don't advise nerve root blocks. Bilateral leg pain, I usually don't advise selective nerve root blocks. Can think about a epidural block, but I don't advise a nerve root block for that. Relative contraindications, the patient has taken the block maybe in the last 1 or 2 months, hasn't got significant relief with it. The pain has recurred in the 10-15 days. And if there is any allergy to anesthetic agents, or patient is on any blood thinners like warfarin or clopidogrel, ecosprin, that's okay. So how do we have the action? There is various reports about, there's nothing conclusive. One of them says that due to they stop the synthesis of pro-inflammatory mediators, there's a local reversible effect. They block the neural blockade. There's a nociceptive input blockade, and this causes the reflex mechanism. There is another theory for that. But there's nothing definitive, but these are two of the theories. So my ideal case for doing a root block is, first of all, there is a proper screening of the patient clinically. Should have a unilateral leg pain, no deficit. A very recent MRI along with an X-ray, the AP and the lateral views. And the OT setup I require is an OT with a proper C-arm where you can see the AP and lateral views properly. So this is a case where I would just show the pictorial images. A male with left-sided radicular pain. I had given him conservative treatment for about 6 weeks, did not any relief, about 3 months duration, no comorbidities. The MRI pictures, if you see, an alpha S1 extruded disc on the left side. with typical left-sided radicular pain. Now for the positioning of the patient, I usually position the patient on the bolster or spine frame. You can position the patient directly on the bed also, the OT table. If the patient is very obese, then you may require a bolster. Place the C-arm opposite to where you're going to give the block. So if you're going to give the block on the left side, keep the C-arm on the right-hand side. What are the requirements? Very simple requirements. You require a local, that is xylocaine or a lignocaine 2%, depomedrol, and a spinal needle, an 18 gauge. Steps. So after patient is positioned prone, you take an AP X-ray and confirm the level that is to be injected. Now the images are not that level because these are the images of a different case which I've done, but basically the steps are same at all the levels. Now, once you've seen the AP image clearly and seen, you tilt the C-arm a little bit 10 to 15 degrees towards your side. So you see a Scotty dog appearance, something like this. Now, why is it important to see the Scotty dog? Is because if you see where the needle finally points, that is where you have the path of the nerve root. So that is where it should be the final position of your spinal needle. Now, once you have seen the AP image and tilted 10 to 15 degrees towards your side, the C-arm, you mark the entry point. And that should be at the neck of the Scotty dog, somewhere here where the needle is there. So at that area, once you have taken the C-arm image, you just locally infiltrate a 2% xylocaine and then advance the needle forwards up to the area where you are able to feel a little bit of the bone. Once you have infiltrated, then you can take your 18 gauge spinal needle and under the fluoro guidance, start advancing it from the entry point up to the area where you reach and you feel a bony prominence. It may be the pedicle or the pars. Just to confirm where is it, you can take a C-arm image. And then you can advance the needle once you have felt the bony prominence, either below the pedicle or the pars, so that you reach to the target area exactly here where you need the needle to be, below the, at the head of the Scotty dog. And in the lateral image, you should have it just below the pedicle, just where it is reaching, where the nerve root is exiting. Once this level is reached, the next is to inject 1 ml of some contrast to confirm that your level is proper and that you're not going very intravascular. So I do aerosol. After injecting it, you can get an image where you have the dye spreading along the course of the nerve root. Once this is confirmed, then you take your local and your depomedrol, mix it. I usually take a combination of 3 cc of local mixed with 2 cc of depomedrol in a 5 cc syringe, and then infiltrate into that local area. The patient, you have to advise him that whatever you're going to inject, he may feel a little bit of heaviness or numbness in the leg, and he will start feeling a little bit of some relief also after injecting the local and steroid. Post-procedure, I just give a small sterile dressing. I advise minimal activities for a day and light activities and walking is permitted for a week. And I call the patient for a follow-up. Till the meantime, I put him on some gabapentin or pre-gabapentin and a muscle relaxant for a couple of days. So what are the benefits of this? When the patient has only a unilateral leg pain, no deficits, and if you want a better pain management compared to oral conservative line of management, which has not given you adequate results, it is really beneficial. Sometimes I've got pain relief for up to a year also in some patients. In a multi-level disc herniation, if you're not sure of the level which is causing the radicular pain, it can be used as a diagnostic tool. And this effect can be last for 3 to 1 year, 3 months to a year also. Thank you.
Okay, thank you, Nikhil.
Yeah.
Gautam, if you are here, are there any questions which need to be addressed in this session?
Actually, Harshad, most of the questions have been answered on the net by all the faculty. So I don't think there is much to be answered here. Just suffice to say that exercise is the key to treating acute back and neck pain patients. Exercises should be done within limits of pain. If any exercise the patient does is aggravating the pain, he or she should not be allowed to do that. Exercises, the frequency is far more important than the duration. So I would rather that a patient does exercises 3 or 4 times a day than do it 45 minutes at one time. As you very rightly pointed out that no specific exercise is superior to the other. However, activity in some form is extremely useful. So that is the crux, and we should go ahead with the next session. Thank you.
Yeah, Thank you. That ends our spinal session. Before we start the next session, I would like to invite Dr. Mohanty. He wants to say some words. And after that, Dr. Swapnil is going to update you on certain activities of the Bombay Orthopedic Society. After that, we'll start with Dr. Pradeep, who will take his ankle session.
Yeah, good morning, friends. First of all, let me thank you, all of you, for coming and joining this session on the YouTube for this first Zoom in meeting of the Bombay Orthopedic Society. Of course, we had our clinical meeting earlier. Today we have our master cares and master shares, and hope you are all staying safe and staying at home. And as long as the government directive of the lockdown is not over, and as long as the government has not permitted us to hold physical meeting, we'll continue to hold all our meetings through Zoom platform. Maybe the next clinical meeting also on the 7th of June at Ayer Hospital will be on June platform as well. So probably Corona has taught us that how to hold online meetings, and there is a better attendance on these online meetings as we see. In addition to this, let me request you that you update your addresses in the directory, because we are going to publish the directory soon, and until now about 800 addresses has been updated, and we have more than 2,500 members. Number two, I urge all of you to join Telegram, because we have made an BOS official Telegram group, and we will be communicating through Telegram, because Telegram can hold up to more than 2,500 members, and we can post all our mailings, official mailings on the Telegram itself. Now we have a great session today, and I thank Dr. Gautam Zaveri, who is the convener for all the master series, and Dr. Harshad Argekar for organizing this master series this time. And of course, in the background, there are so many people who are working. I just wanted to convey our gratitude and thanks to them. Dr. Swapnil Kedi, our honorary secretary, Dr. Satish Chaudhary, Dr. Mahesh Khade. Now they have all been instrumental in doing this Zoom meeting possible. I thank you, and let us continue with this excellent meeting. Thank you all, and have a nice day.
Yeah, Swapnil, you wanted to say something?
Yeah, a very good morning to all the viewers and all the members of the Bombay Orthopedic Society. I hope all of you all are enjoying this webinar on office orthopedics. I just wanted to update you on the Telegram channel which the Bombay Orthopedic Society has started. So we have a lot of exciting announcements, and a lot of exciting sessions will be announced. A lot of information will be shared. So I request all the viewers and all the members of the Bombay Orthopedic Society to kindly subscribe to this channel. I thank all the faculty who have spoken and all those who are yet to speak. And with this, I would end my short talk, and we'll move on with the session. Thank you so much.
Thank you very much, Swapnil. So Pradeep, are you ready to share your presentation?
Yeah.
Please do that. We are starting the ankle session. We have Pradeep, followed by Dr. Rajiv Shah, and other faculty who will solve your problems about ankle pain. So Pradeep, you can start.
Sure. I would like to say thank you very much to the Bombay Orthopedic Society and all its members for giving me this opportunity. I will be talking on approach to heel pain and forefoot pain, which I think is an enigma in, hold on. Yeah. Can you see it?
Yeah.
Excellent. So my talk is divided in two parts: approach to heel pain and approach to forefoot pain. So most common diagnosis in the heel pain is plantar fasciitis, but that is not the only cause. And we need to understand what are the other plethora of conditions that contributes to this condition. So let's talk about what are the sources or structures which can cause heel pain. Of course, there's tendons and fascia, neural sources, and bone and joints. Looking at the tendons, of course, the most common is plantar fascia, but there are other things as well, like Achilles tendon, we know that, FHL, tibialis posterior, and peroneal tendons. Looking at the neural sources, we know a tarsal tunnel syndrome or compression of the Baxter's nerve, or the first nerve, can cause heel pain. Spine or sciatic nerve entrapment can also give rise to heel pain as well. And coming to bone and joints, of course, calcaneum stress fracture, any previous injuries, previous fractures, calcaneum fractures, arthritis and infection can also give rise to this condition. So how I divide and how I look at heel pain and approach to heel pain depends on where the pain is. Is it posterior or inferior? Is it medial or lateral? So according to the anatomical side, you can get a good idea of what are the common causes of it and less common causes. So let's start with the inferior cause of heel pain. The most common cause we know is plantar fascia, but don't forget the other less common sources could be compression of the medial or lateral calcaneal nerve. But do not forget this entity called as a calcaneum fat pad atrophy can also lead to inferior heel pain. Posterior heel pain, common causes are of course Achilles tendinopathies or tendinitis, but do not forget you can have an isolated superficial calcaneum bursitis, a stress fracture, posterior impingement also called as osteogonum as well, or calcaneum apophysis in adolescents. Less common sources are sural nerve, sural neuroma. Looking at the medial side of the heel pain, common causes are tibialis posterior tendinopathy or tibialis posterior insertion and apophysis in adolescent or leading to accessory navicular issues. Less common sources are FHL and its sheath, so FHL tendinitis, or you can have an abductor hallucis giving rise to the pain. Deltoid injuries or spring ligament injuries or chronic issues with that. Posterior tibial nerve compression in the tarsal tunnel can give rise to medial side pain. Or if there are any bony lesions in the medial malleolus, I had a case where there was a large cyst of gout in the medial malleolus replicating like a heel pain. Lateral side, common sources is lateral ligaments of the ankle or a sinus tarsi. Less common sources are peroneal tenosynovitis. You could have a calcaneal cuboid or cubometatarsal arthritic pain or peroneus brevis insertion or apophysis of the base of the fifth metatarsal in adolescent or after an ankle sprain. Now, how do you go about assessing these people? You need to look at different factors like age, the pain aggravators, the pain behavior, pain with incidence, any red flag signs, and other issues which will come, which will give you a fair idea or narrow down the diagnosis. So let's look at age. If it's a young patient, we know it's a Sever's disease, a calcaneum apophysitis, or you can have a calcaneum stress fracture or tumor. Middle age, the most common cause is either plantar fasciitis or Achilles tendinopathy. Older patients, tibialis posterior tendinopathy is common. What aggravates the pain? If it starts after walking or running, like a mechanical cause, then you're looking at an insertional tendinopathy, and especially if you have a paratenon of the Achilles tendon involved, that can also give rise to increased pain after running or walking. Of course, stress fracture or stress reaction or any neural issues can give rise to increased pain. Non-mechanical issues, you're looking at pain at rest because of, again, nerve issues, or pain on rising after sitting or after rest is a hallmark of tendinopathy, like Achilles or tibialis posterior tendon. Was the onset pain associated with an incident? Yes, like after running or footwear, you have Achilles tendinopathy or a stress fracture. If it is no, you're looking at an arthritic cause. Pain behavior. Morning pain and stiffness, again, plantar fasciitis and Achilles tendinopathy is common. You can have these symptoms in FHL tenosynovitis. And if it takes more than an hour to warm up, you start thinking about inflammatory arthropathy. While if it is night pain, you're looking at any sinister causes or stress fracture. So again, night pain, other red flag signs like loss of weight, night sweats, and other joint swellings, you're looking at inflammatory arthropathy, infections, or tumor. And if there is any past history, you're looking at posterior impingement syndrome or any arthritic changes. Others, like if you have cramps in the calf and feet, think about vascular claudication or can be an early indicator of bone stress. And if you have nerve issues, then your sharp pain, burning, pins and needles or numbness, think about tarsal tunnel syndrome or posterior nerve impingement. Now coming to objective assessment, what are they looking in inspection? Are there any swellings, abrasions or rashes present? You have any Achilles tendon swelling, both either at the insertion or just above the insertion for non-insertional tendinopathy. You're looking at the alignment in standing position from the front and the back to check for any pes planus, pes cavus, or any other deformity or any shortening. And of course, looking at the calf wasting as well. When you look at a palpation, you start with a a methodical way of examination. You can start with clockwise or anti-clockwise. You look at, you start with the plantar fascia attachments, look at the insertion of the Achilles tendon, tibialis posterior and FHL you can palpate, apophysis, where exactly the bone stress or the sites of pain is, sural nerve and sinus tarsa pain. These are all the places where a patient can be tender and still have plantar fasciitis. So it's not necessary you have to have right at the bottom or the center. It could be here or in the middle as well. I've had reasonable number of patients with that. Now coming on the medial side, if you have pain, this area, you're looking at a compression of Baxter's nerve. Pain on the medial or the lateral side in the center of the calcaneum, think about stress fracture. Pain on the medial inferior side, think about plantar fasciitis and heel pad atrophy. Coming on the lateral side, pain just behind the posterior lateral malleolus, peroneal tendinopathy, or a posterior impingement could be a differential diagnosis. Pain on the lateral side of the calcaneum, stress fracture, or in the sinus tarsa area, looking at sinus tarsa syndrome or an arthritis changes. Pain on the posterior aspect in the mid part of the Achilles tendon, you're looking at non-insertional tendinopathy. Pain around the Achilles tendon, in front of the Achilles tendon, think of retrocalcaneal bursitis at the insertional tendinopathy. Do not forget to test individual muscles, especially tibialis posterior muscle, and also peroneus by doing either dorsiflexion and eversion and plantar flexion and eversion to check for subluxation of the tendons. Ask the patient to do a single leg and a double leg heel raise. And if he's not able to do it, think about Achilles tendon rupture or tibialis posterior tear. Look at the special test. Now this I would advise everybody who's having heel pain to have it done where you hold the heel with both your hands and you compress it. And when you do a compression, look at the face of the patient and he as you compress it, look at the face and you see how he winces. And he winces. Yes, you see that he winces, and that's a hallmark of a stress fracture of the calcaneum. Homan stress, I'm sure you're able to, you should be able to do it where you squeeze the calf, and there's no movement of the heel at all. And this is on the normal side where you squeeze and there is movement of the heel and the foot. Posterior impingement, you can do it in prone position where you the heel is compressed and you do an extreme plantar flexion and patient complains of pain at the back of the ankle. Yeah, this is FHL tendonitis. You dorsiflex the great toe and you can feel tenderness at the back of the ankle as well. Clinical assessment remains the most important tool for all heel pain patients. Of course, you can do other simple tests like plain x-rays to rule out other pathologies, which I've already mentioned. Ultrasound, lab test, ESR, CRP, uric acid, rheumatoid arthritic, and MRI bone scan and EMG has its role in the later part of your investigation. So just a few examples. This is a patient who came with heel pain on the left side, and she was 6 to 8 weeks down the line. And here, of course, you can see how the stress fracture is showing in the healing phase. Look at the MRI scans, a lot of edema present, and that's the fracture line seen clearly. This patient came from Bangladesh with heel pain, and I suspected something is happening here. Got an MRI done, and then he had osteomyelitis of the calcaneum. This patient came with pain at the back of the ankle joint, and there you can see an osteogonum. This patient, a staff of Breach Candy, with pain in both the heels and then a sudden giving way sensation. So he had Achilles tendinopathy, and along with it, he had a rupture of the insertion of the Achilles tendon. So as I said, role of ultrasound is good for, say, manage or diagnosing retrocalcaneal bursitis, Achilles tendon tear, or any space-occupying lesions in tarsal tunnel. While MRI would be helpful if you're suspecting a stress fracture, a tear, a tendinopathy, plantar fasciitis, and especially plantar fasciitis to rule out other causes of heel pain. And at the same time, you could do a measurements of the plantar fascia as well. EMG and NCV studies can also be done if you're suspecting a tarsal tunnel syndrome. So in summary, heel pain is usually of mechanical origin. The most valuable approach to use the site of pain to narrow your potential diagnosis, and imaging can assess, however, should not replace a clinical assessment. So I will continue next to approach to the forefoot pain. So metatarsalgia refers to forefoot, so pain in the forefoot under the metatarsal head region. But Metatarsalgia is a symptom, not a diagnosis. And again, there are a plethora of conditions that contribute to metatarsalgia. So look at the contributors. You have the great toe, you have the lesser toes. Hind foot can also lead to forefoot pain. Ankle pathology, as well as any issues in your calf or gastrosoleus, can cause metatarsalgia. Now, the metatarsalgia can be classified into primary, secondary, and iatrogenic, where the primary is usually because of either a long second metatarsal, a plantar flexed first ray, or an incompetent first ray and congenital deficiency. Secondary metatarsalgia is because of the plethora of conditions like hallux rigidus, trauma, inflammatory arthropathy, instability of the metatarsophalangeal joint, plantar plate injury, Morton's neuroma, and Freiberg's. Iatrogenic is either because of a failed reconstructive surgery or any surgeries done on hallux valgus leading to metatarsalgia. So let's look again at the site of pain. Either it could be because of the plantar side or the dorsal side. Looking specifically on the dorsal side, what are the common causes of metatarsalgia? Is hallux rigidus, gout, hallux valgus, stress fracture, and Morton's neuroma. These are the common causes. Less common are Freiberg's, midfoot arthritis, inflammatory arthropathy, bunionette, and intermetatarsal bursitis. While on the plantar side, you have corns or callosities, you have Morton's neuroma, and a tight gastrosoleus complex can lead to plantar side forefoot pain. And less common sources are malunited fractures of the lesser toes or great toe, sesamoid fracture, sesamoiditis, or turf toes. So again, looking at the specific questions, what are the pain aggravators? Look at where the pain is in the foot during the gait cycle. Any neurological issues like pain, burning sensation, or tingling sensation in the toe. Any history of trauma, any high energy or fractures present. The joint involvements that will lead to the diagnosis of any inflammatory arthropathy. Last but not the least, always ask for diabetes because of vascular claudication or peripheral neuropathy can lead to forefoot pain. Now, during the gait cycle, where the pain is, if the pain is during the heel strike, you're looking at cavus foot or a tight heel cord. If the pain is during the midstrand, you have arthritic. But if the pain is in the toe of time, then you're thinking of either MTP instability or hammered toes. Looking at this inspection, always examine this patient in the standing position and in the sitting position from the front and from the back. Do not forget to assess their footwear as well, and especially in hammer toes and other deformities, where you can see the bulges on the dorsum or the outside or the inside of the footwear. That is almost a key thing to be done for these kind of patients. Obviously, look at significant deformities like hallux valgus, hallux varus, lesser toe deformities. Any swelling present in the forefoot area, any callosities or ulceration on the plantar aspect of the foot. Don't forget to measure the limb lengths because a patient with a limb length discrepancy can have mild equinus, forefoot overloading, and pain in the forefoot region. Palpation, the key thing in this is ask the patient to exactly pinpoint where the pain is, because there are multitude of causes of forefoot pain. And if you get the patient to pinpoint it, you narrow the diagnosis and thereby narrowing the investigation as well.
You'll have to wind up in 2 minutes, Pradeep.
Okay, I think I have 4-5 minutes. Okay, so dorsal side. Okay, I'll finish it. Hallux rigidus, gout, bunion, IP joint arthritis, MTP synovitis, stress fracture, Morton's neuroma, bunionette, and midfoot arthritis on the dorsal side. Plantar side, sesamoiditis, sesamoid fractures, long or plantar flex ray, insufficiency first ray, bunionette, and tight gastroc and plantar fat atrophy. Special tests, do not forget silver coil, Mulder's, draw test, and hypermobility test. A difference in dorsiflexion of around 10 to 15 degree between knee flexion and knee extend shows gastroc is tight. Morton's neuroma, hold the foot with one hand, squeeze it, and gently with the other hand, check if there is a Mulder's click. Do a Lachman's by stabilizing your metatarsal with one hand and hold the proximal phalanx with the other hand and do dorsiflexion and plantar flexion to check if there is instability. As I said, clinical assessment remains the most important goal. You can have other investigations like bloods, ultrasound, and MRI. Do not forget weight-bearing X-rays is the key to diagnosis, because what you want to see is a parabola on a standing X-rays. How do you know if it is a long first ray or a second ray? Maestro has given this, where you draw the M2 axis, draw the fibular sesamoid, a perpendicular line from the sesamoid should cut through the fourth, and difference between the M1 and M2 should be less than 3 millimeter. Here is an example where the second metatarsal is long, first is short, and you have an overloading with callosity here. X-rays showing hallux rigidus with a long first ray, and that's why you have a rigidus and a dorsal osteophyte seam. Patient with non-rheumatoid hallux valgus, one side hallux varus, and severe multitude of lesser toe deformities seen here. X-ray showing a stress fracture of the third, and X-ray showing a Freiberg's, again weight-bearing X-rays. These are special sesamoid X-rays here because a diagnosis is either a avian sesamoiditis or sesamoid fracture. You can do ultrasound where you are suspecting Reumontans, MTP synovitis or bursitis. Rest of the stuff, probably MRI is better. And in conclusion, I would say there are several causes of metatarsalgia. A complete clinical and radiological examination is required. Do not forget weight-bearing, dorsoplantar, lateral and oblique views to check for lengths of the first and second rays. And ultrasound and MRI scans with a marker is helpful. Thank you very much again for giving me this opportunity.
Thank you, Pradeep. I will ask you to stop sharing your presentation so Dr. Rajiv can start his talk. Dr. Rajiv is going to talk to us about ankle and foot orthosis, how to evaluate, how to prescribe, and how to monitor footwear, and what modifications you need to do so as to help patients in ankle pain. Dr. Shah, you can start your, you can share your screen.
Good morning and thank you very much, Bombay Orthopaedics Society. I hope I'm audible and my slides are visible.
Audible, sir. You go to slideshow. Yes, everything is visible now.
Yeah. So let's start with the case. Female 42 presents with a plantar heel pain of 3 months, tried with medicines and silicone heel cushion prescribed like this. With 5 consecutive visits, patient did not improve. Case number 2, male 39 with a plantar heel pain of 5 months. This time surgeon diagnosed that this patient requires a customized heel cushion with this kind of arch modification, but 5 good visits, patient was same. Case number 3, female 39 with pain in heel from 4 months, had a flat feet, as diagnosed by the surgeon, and arch support and silicone heel cushion advised like this. 5 consecutive visits, still patient was same. So 3 similar cases with the age group between 39 to 42 and heel pain of 3 to 6 months, orthotics and footwear modification prescribed, but all of them they failed to improve the patient. Why? What went wrong? Let's see the cases. The case 1, where a soft silicone heel cushion was prescribed, was not evaluated with a standing examination and had a flat foot with heel valgus. In fact, it required a medial arch support with the medial heel post. So it was a problem of evaluation on the part of a consultant. The case 2, where it was diagnosed and prescribed to go ahead with a customized arch support, in fact had a cavus foot and a varus of the heel, which was a thing which required a arch support plus a lateral heel wedge, was a problem of a prescription. And the last case, when everything was right, the orthotic prescribed was very high, very hard material and required change of material and reduction of the height of the orthotics. So it was a problem of monitoring. So that's what today I am going to discuss: evaluation, prescription and monitoring of orthotics and footwear modifications in our outdoor. For evaluation, there are 6 basic fundas. Make your patient stand, let them turn around. Most commonly missed clinical evaluation is detection of the arch abnormality. May it be a flat foot and a heel valgus or a cavus foot and heel varus. Make your patient stand, examine them from the back. Look at the sole of the foot. Sole of the foot is going to demonstrate certain pressure areas onto which you can address your orthotics. Check for the sensations of your patient. Insensate patient would require different kind of orthotics and close monitoring. Evaluate tendo-Achilles. Tendo-Achilles tightness, as Dr. Pradeep showed, should be evaluated and addressed. Look at this patient who had a con non-healing just was because of the tight tendo-Achilles, and relief of the gastrocnemius relieved him. Make your patient walk. This patient on standing showed just a slight heel varus, but when this patient was made to walk, it was drifting outwards laterally and required completely change of the orthotics. And the last important part of the evaluation is to examine the footwear of the patient. Footwear which is quite ragged, footwear which is very tight, very lax, like this, could give rise to multiple other secondary problems. Then comes the art of prescribing a footwear modification. Try and get answer of 3 questions: why, what, and how. Why do you want an orthotic or a footwear modification for a given case? What is the function you want to do? Is that you want it for reduction of an impact, like in a case of plantar heel pain? Or you want to offload a pressure area, like in a diabetic ulcer or a cone? Or you want to correct a flexible deformity? Or you want to accommodate a rigid deformity, like in stage 3 and stage 4 of flat foot? Or the 5th function is you want to limit or restrict excessive motion going over the arthritic joint. And the last one could be you want to compensate for the restricted motion, where you have a fixed deformity, where you have done an arthrodesis of the ankle. You want to compensate for the restricted motion. You use orthotics and footwear modification. The second question is what type of orthotics you want. Is that you want a soft device? When you want to accommodate a deformity, you want a soft device. When you have a neurovascular jeopardy, you have a soft device. All over the counter products are soft device for heel pain, toe deformities, which we very commonly use. The rigid devices are meant for correction of the flexible deformities, but you must observe for the skin issues, patients with lack of sensations, and the compliance part is also to be monitored. And semi-rigid devices are meant for support, correction, or for both. They are easily modifiable. Patients are highly compliant to them. And these are the majority of the orthotic and footwear modifications which we prescribe today in our practice. And the last question is, how are you going to make an ideal or a rational footwear modification or an orthotic prescription? A typical prescription of mine would have name, age, and diagnosis of the patient. I am going to specifically mention about the sensory level of the patient. And the purpose of the orthotics or a footwear modification is that I want it to support, I want it to offload, I want it to accommodate, I want it to correct, I want it to restrict, or I want it to compensate, or maybe I want 2 or 3 combined functions. And what would be the type of it? Soft, semi-rigid, or rigid? On the second page of the prescription, draw a foot diagram and draw a diagram of modifications where you want what you want. And then the last part in the outdoor is monitoring of a footwear modification. So when a patient comes to you with a footwear or modification or an orthotics at the first visit, what do you look at? You look at the quality of material used. Is it the soft material, firm material, or a hard material? Very hard material or very soft material, you will have to be watchful. Look at the position of the support. Where has it been kept? Is it at the precise location, or it is proximal, distal, medial, or lateral to the problematic area? This orthotics, when I asked patient to remove and stand over it, it was quite longer than the foot, will not work. You also look at the pressure effect generated by the orthotics or footwear. Look at the impingement or even lack of the support by the orthotics. Make your patient stand, walk over the orthotics and ask for the level of comfort. This patient, when was asked to stand over this orthotics and footwear modification, look at the way foot was going away from the orthotics and support, and this is not going to work. In the subsequent visit, look whether this impingement, this orthotic is not impinging. Are there any secondary skin issues? Are there any pressure changes? Then you need to alter the orthotics. You also look whether this orthotic is working. Is it getting more deformed? Footwear is getting deformed. Then I think you need to move to the stage 1 to stage 2. Like in a flat foot, we would move from UCBL to supramalleolar orthosis if UCBL is not working. If it has served the purpose in the subsequent visit, you might like to downgrade your orthotics. Maybe you more would like to go from SMO to the UCBL, which will make your patient more compliant and comfortable. In the subsequent visit, you also take standing X-rays with the orthotics on to really evaluate the efficacy of the orthotics. This is the X-ray I took of a patient with Charcot who is having a dropped arch even with the orthotics on and requires surgery. So that's what is a very, very important message. Orthotics and footwear modifications cannot correct a rigid deformity. They are more often than not meant to fail. And when they fail, surgery would take over. Orthotists and prosthetists are highly constipated guys around us. They would never leave a non-responding patient. It is the job of a surgeon to come up and say that, look, this is not working. You need surgical offloading. Look at this case of male 28 who had 12 years of non-healing ulcer in a case of operated meningomyelocele, which was being treated by multiple orthotics of my city. And in a standing X-ray, patient had a wrong axis, a valgus axis of the ankle and foot with arthritis of the joint. And this is how the foot scan showed it and just required a corrective fusion. And on correcting axis surgically over 6 weeks, the ulcer which was not healing from 12 years just healed. So that's where I want to say that they let the wisdom of a surgeon, orthopedic surgeon, prevail in evaluating, prescribing, and monitoring orthotics and footwear modifications. That's all. Thank you very much. Thank you, delegates. Thank you, Bombay Orthopaedic Society.
And thank you, Dr. Rajiv Shah, for touching upon a topic which generally most orthopedic surgeons would just refer a patient to an orthotist, and that's the end of it. So I think that was a very interesting talk and very nice information. So please be around for the questions, which will be there on the YouTube chat. And now I request Dr. Abhishek Kini to share his presentation. We will be talking about various injection techniques used for ankle and foot.
Yeah. Hi. Good morning, delegates, respected teachers who are in the virtual audience. So I'll be briefly talking on injection techniques in foot and ankle. Yes. So injections can be diagnostic as well as therapeutic. Most common areas that are injected in foot and ankle are plantar fascia, ankle and the subtalar joint, the interdigital space for bursas and neuromas, the first metatarsophalangeal joint for gouty arthritis and other forms of arthritis that involves there. Lastly, but very precautiously, retrocalcaneal bursa and Achilles tendon. So what do we inject? It can be a local anesthetic for differentiating the causes of pain, a cortical steroid to kind of bring about an anti-inflammatory response, or sometimes biologics which are available now in market like the PRPs and other stuffs for intratendinous injections. Without wasting much time, most common plantar fascia, which is like we use a thin 25 gauge needle, which we need a longer one, 1.5 inch long, normally up to 5 ml of our mixture that we take. Confirm the painful site where it is. Draw a vertical line following the posterior tibia. Draw a horizontal line along the inferior margin of calcaneum and then inject medially. So I enter from the midline, I enter from medially, cross the midline, aspirate and inject as you withdraw the needle. Be careful to avoid spillage in the fat pad, which can cause atrophy as Dr. Moonot just described. Next, very common, very easy to do it, ankle joint. Again, a short needle for injection or a thicker needle, 18 gauge for aspiration, and always do it under local anesthetic. Up to 10 ml of fluid can be injected in the ankle. Follow the medial tibial shin up to the ankle joint. That's medial to the tibialis anterior tendon. Spot, confirm that it is a soft spot. Move the ankle dorsiflex, plantarflex up and down so that you confirm that it's the ankle joint, and inject, directing it posterolaterally. So you go from anteromedial and direct it posterolaterally. You should feel a free flow of fluid into the ankle joint because it is a cavity joint. So you should take in fluid very easily. Next, subtalar joint, again common, as doctor said, like, sinus tarsi syndromes, subtalar arthritis. It can take up to around 5 to 8 ml of our fluid. Follow the lateral malleolus anteriorly. You feel a dip, that's the sinus tarsi. Confirm the soft spot by inversion, eversion, that you confirm that you're in the subtalar joint. And over here, you inject it posteromedially. So you go from anterolateral and direct it posteromedially. Again, you should have a free flow. Sometimes you do it as a differential injections between ankle and subtalar joint, and you can also do it under C-arm guidance. Next common space is an interdigital space where you can have a bursitis, like an interdigital bursitis, or a neuroma. You need to confirm. So over here, I normally draw my anatomy on the foot, which helps me kind of, not miss the target. It can take up to 5 ml of fluid. Palpate the bony landmarks, draw the metatarsal shafts, metatarsal heads, metatarsophalangeal joints, palpate where the tender spot is, confirm the diagnosis. Bursitis is more proximal between the shafts, while neuromas are slightly distal in between the heads, as drawn in the diagram. So while injecting, slightly plantarflex the foot, enter at around 45 degrees and direct it from distal to proximal and inject. Be careful not to overspill it into the plantar aspect, which can again cause a fat pad atrophy in the forefoot and cause metatarsalgia. Next is metatarsophalangeal joint of the first toe, that is the great toe. You need a short needle, 25 gauge, up to 5 ml of fluid goes in. Support the foot firmly on the bed. Palpate the metatarsal shafts, head, and the MTP joint. Confirm by dorsiflexion, plantarflexion movement of the great toe where your joint line is. Mark it. And while injecting, a trick is to give a gentle traction to the great toe and inject it at around 60 degrees, directed distally, as shown in the picture. And you again, like a joint, you should get free flow over here. Last, very careful, you need to inject the retrocalcaneal bursa or the Achilles tendon. Make sure that where the pain is coming from, you need a thinner 25 gauge needle up to 10 ml. Anatomically, you have to draw the retrocalcaneal bursa, which is anterior to the Achilles tendon, unlike the superficial calcaneal bursa, which is posterior. We are dealing with the posterior part of the hind foot. So be careful where your joints are. I injected prone with a knee slightly bent. I palpate and mark my Achilles tendon. Mark the tender point where it is, and while injecting the retrocalcaneal bursa, you need to inject while directing it anteriorly so that your injection, if it contains a corticosteroid, doesn't come in contact with the tendon which is already degenerate. Yes, you can inject intratendinous, especially those biologics which are available, PRP. Again, you need to mark the tendon, go transtendinous and inject wherever the tender spots are. So retrocalcaneal bursa and Achilles tendon, you need to be extremely precautious while doing your injections in these areas and not cause an iatrogenic ruptures. Thank you, gentlemen.
Well, thank you, Abhishek, keeping it to point and absolutely perfectly on time. I will then now like to invite Dr. Anil Karkhanis for his talk. So Abhishek, you need to stop sharing your screen.
Done, sir.
And I will invite Dr. Karkhanis, and we'll start his talk.
Thank you, Harshad, for giving me this opportunity to speak on the Bombay Orthopaedics Society Master Course today on 3rd of May 2020. I am going to talk on management of ankle sprains, common foot exercises for heel spur and PA tendinosis, and walking aids. So the deltoid ligament is the strongest stabilizer on the medial side, but it is usually involved in pronation and external rotation injuries of the ankle. So pronation, external rotation injuries of the ankle, these are usually associated with fractures of the lateral malleolus with diastasis of the tibiofibular syndesmosis or fracture of the neck of fibula called as Massillus fracture. Here, either the deltoid ligament gives way or there is a fracture of lateral of the medial malleolus. On the lateral side, we have got these strong ligaments. There is the anterior talofibular ligament, middle calcaneofibular ligament, and posteriorly the posterior talofibular ligament. Besides this, commonly in the sprains, we have got this ligament which is going from the calcaneum to the talus, and that is the calcaneo-talar ligament. So normally you get what are known as the inversion sprains, and they will be in the grade 1, grade 2 or grade 3. Grade 1 are the sprains of the anterior talofibular ligament. Along with that, if the other ligament breaks, then it is grade 2, that is the calcaneofibular ligament. And lastly, if all the three ligaments give way, but this is very rare, then there will be grade 3. Now, what about the patient? The patient who has got this inversion sprain, this is very common. What will he have? He will have normally sprain of the anterior talofibular ligament, in which case the anterior talofibular ligament will have tenderness at this spot. What are the other things that you must see for the ankle sprain? The second thing that you must see is tenderness at the base of the fifth metatarsal, that is called as a Jones fracture or avulsion fracture of the insertion of the peroneus brevis. This is the second point which I told you. And if the patient has got tenderness solely over here, it is the sprain of the anterior talofibular ligament. Lastly, this is a very important sign given in the textbook, and that is if you run your finger along the posterior border of fibula, and if there is tenderness, then the chances 80 to 90% the patient will also have a fracture of the lateral malleolus. This is a very important sign, and that is running the finger along the posterior border of the fibula. So what are the treatment options? Most of the sprains are not treated by surgery. This is a very important point which I want to make. Reconstruction is a better option. Minor sprains are treated by crepe bandage from 8 a.m. to 8 p.m. along for about 2 weeks along with NSA. Major sprains are treated with BK fiber cast and continued till the patient can walk on the cast. Don't remove the cast till the patient says that he can walk painless on the cast. So this is how he will walk. The patient is walking. The affected walker first, affected leg, then the other leg. Walker first, affected leg, other leg. The other leg must cross the affected leg. This is how he will walk. Now this patient is walking on the walker, but that is not enough. Now the patient has to walk in a gait which is normal gait. In which case, what he will do is over here, he will put this leg first, and then the unaffected leg must cross the affected leg. Unless and until he can walk that way, don't remove his cast. Affected leg, normal leg. Affected leg, normal leg. It must cross. This is the time when you can remove the cast. Subsequent to removal of the cast, what the patient requires is how to put the patient into crepe bandage. And the crepe bandage after removal of the cast must remain at least for 3 to 4 weeks. What is the method of giving a crepe bandage? The crepe bandage of the ankle is normally 4 inches, and you should never take the heel. I will show you this video how to put the crepe bandage. timing of the heel from 8 a.m. to 8 p.m. at least for 8 weeks. And the patient has to walk similarly in the heel-toe gauge. Don't take the heel. 4 inches, crepe bandage, put the clip, and now the patient has already walked on the cast, so therefore he can walk on the crepe bandage. When you do all these things, you'll find that the patient then does not have any edema, which many a time these patients come with, mere paon pe sujan hai, this, that. This will never happen if you follow these steps. Now this is how he will walk, and this is called as the heel-toe gait, heel strike, stance, heel off, toe off. This is how he should walk. Because many a time the patient does not walk this way, and he will get pain. So that way. Heel, stand, heel off, toe off. Heel, stand, heel off, toe off. Heel, stand, heel off, toe off. Only if he walks this way, the patient does not have any swelling on his foot. These are the steps you must follow: cast, crepe bandage, and walking. Now I will go to two conditions, and that is common. What is the calcaneal spur and retrocalcaneal spur? Now, what is the cause? Actually, the cause is the effect. The effect is because of tight plantar fascia. The tight plantar fascia will pull upon this calcaneum and it will form a spur. Similarly, the tendo-Achilles, when it is tight, it will pull upon the tendo-Achilles insertion and it will have a spur. So it is the effect. It is not the cause. And what is the remedy for that? The remedy is absolutely perfect. And that is something that you make the patient to ask him to get a 1-inch plywood, keep it on the wall. The plywood should be at the level of the metatarsal head. The heel must touch the wall and the ankle should be straight. This he has to do for 10 minutes. Moment this patient does that, even in the clinic, he will say, where is my pain gone? He will have no pain in the calcaneal spur or the tendo-Achilles tendinosis because they are the effect and not the cause. The effect being tight plantar fascia and tight tendo-Achilles. Subsequently, you ask the patient to stand for only 3 minutes on the society. This is a stool which is in my clinic, but the patient need not have a stool. He can have the step in the society. What will he have to do? He'll have to hold somewhere and his foot should be at the edge of the step so that not only the plantar fascia will lose out, it will stretch out, but even the tendo-Achilles, which is causing tendo-Achilles tendinosis, will relax and the patient will have no pain. I have yet to have a patient who has come back with pain. It's absolutely 100% very useful step. Now I'm going to talk on walking aids. Very important. Many of you don't know how to use the walking aids. So let's see how to do that. Climbing up the step with the walker. Foot goes up. Stabilize the walker, railing. Now he's going down. So bad goes down, the right leg is bad. This is coming down, bad goes down, walker, stabilize the walker, bad goes down, good leg. Once again, stabilize the walker, right hand is on the railing, bad goes down, good comes after that. Once again, stabilize the walker, bad goes down, and that's the end of going down. Climbing with a stick. How does the patient climb with a stick? Foot goes up. So, good leg and stick. Good leg and stick. is done by my first year house surgeon, Dr. Ghosh. How to go down. That goes down as I showed you. So, bad leg, stick, bad leg, stick, bad leg, stick, bad leg, right hand on the railing or whatever, left hand, right hand, whatever railing you get. Stick, bad leg, and that's the end of it. Okay. Now we go to the next one and climbing up that we have done, coming down with the stick we have done. And now, very important, how does the patient sit on the chair or commode and how does he get up? That we never explain to the patient. This is how we do. Walker, bad leg, good leg. Walker, bad leg, good leg. Walker, even if it's a stick, walker and bad leg. Stick and bad leg. Now the patient will turn. After turning, this popliteal surface must touch the chair or commode. Then he will sit. While getting up, he has to once again bend forwards. He will push himself forwards. And then he will get up. Once again, walker, bad leg, walker, bad leg. This is the instruction that we must give to the patient and they are really happy on what we do. Walking with the crutch. Walking with the crutch, again same thing. The crutch will go forward. Along with that, it swing because now this is non-weight bearing crutch walking. We tell the patient non-weight bearing crutch walking. लेकिन कैसा करना है? That is how we will teach, and that is the patient will swing the normal leg. Yeah, this is the video. So swing the normal leg. Swing the normal leg. So what will happen is the stick will go forward and swing the normal leg, and of course the non-weight bearing will follow again. I'll show you once again because this is a fast video. He will take the stick forward, then swing. Notice. Crutches, normal leg, crutches, normal leg, crutches, normal leg, crutches, normal leg. Non-weight bearing. If it is a weight bearing, what is the solution? Crutches and bad leg. That is how it will do. Okay. Now, lastly we come to, now we don't know how to give the instruction. What is the height? Many times this height of the handle is over here somewhere. No. The height of the handle of the stick adjustment is at the wrist so that the patient will get about 10 degrees or 20 degrees flexion at the elbow. Normally it is 30 degrees. So what will happen is many a time the patient will come at the stick like the prod. No, this is the too long in the handle over here at the wrist level and this will come over here. This is exact. And the patient will walk once again stick and normal leg. This is how we'll do. Stick, bad leg, stick, bad leg, stick in opposite hand. Stick, bad leg, stick, bad leg. Once again, return. Stick, bad leg, and stick, bad leg. This is how the stick in the opposite hand will go with the bad leg. So friends, today at the Bombay Orthopaedics Society Master Course, I have said some very important simple things, starting from the sprain, calcaneal spur, retrocalcaneal tendinosis, and how to use the walking aid. Harshad, I am very thankful that you allowed me to do this presentation because it is so basic that even the registrar who passes PhD or MS on may not be knowing this, but this will be a lifetime teaching for all of them. Thank you very much.
Thank you, Dr. Karkhanis. I think we come at the end of this ankle foot session, which I think all my viewers here will agree was incredibly useful for the general orthopedic surgeons, because ankle foot pain is so common in general practice and we are at a loss how to diagnose it. That I'd like to ask the first question to Pradeep. Pradeep, are you online?
Yes, I'm here.
Yeah, so Pradeep, the question to you is subtle. A lot of elderly ladies, 60s, 70s, obese, come with pain just below the malleoli. When you examine them, they have synovitis, from which seems to originate from the subtalar joint. So clinically, how do you diagnose a subtalar joint arthritis? Then what is the treatment modality you would follow in this patient subsequently?
Okay, I think that's a very, very good question, Harshad. The key thing in your history is what you have to ask. How do you diagnose a subtalar early arthritis? Is you ask them when it hurts and does it hurt when they walk on a level surface or an uneven surface. If they say that even if they walk on uneven surface with shoes or without shoes, or with footwear or without footwear, uneven surface walking is a bigger issue than a level surface warning. It is pointing towards your subtalar joint. And of course, tenderness just below the lateral malleolus. As you said, if it is tenderness further anteriorly around that J-shape area, you're looking at an ankle sprain or synovitis in the lateral gutter. But really down below, that is sinus tarsi pain. And then the other thing is, what you could do is in your clinical examination, you stabilize with one hand, your dominant hand, the talus, you hold the heel or the calcaneum in the other hand and rock the heel over the talus. If she says, yes, I'm getting the same pain over the sinus tarsi area, then you can be sure it is coming from your subtalar joint. Third thing is get weight bearing x-rays. Normally you may not get especially in early arthritis, you will not be able to see significant, but if you do weight bearing standing AP and lateral x-rays standing and compare it with the normal side, you may see a joint narrowing. And then you can do it further, getting other investigation like MRI. Now, treatment wise, again, anti-inflammatories, cold fomentation or hot fomentation, and ask them to wear good footwear, especially when they're going out of the house. If this doesn't help, I do subtalar joint injections, but I do them under CM guidance. If that fails, then you have a fusion option.
Yeah, Dr. Rajiv has a question.
Thank you very much, Dr. Rajiv Shah. I would like to ask the question before you mention is, Pradeep just mentioned that you should advise him good footwear when he leaves the house in subtalar joint. What sort of shoes should you advise this patient?
Yeah. As I said in my talk, that for an arthritic patient, we want to limit the excessive movements going over that particular joint. And for that, we will need, in a very bad case, we need an ankle foot orthosis. Going down from there, you need a kind of Arizona brace, which would limit the joint movements. You could even have a stiff footwear. You could even think of giving a rocker. And if there is a varus or valgus deviation of the heel, you put a post on the opposite side to balance the same. But what I wanted to add with respect to the subtalar joint evaluation is that two important points. In foot and ankle, it is the finger which does the trick. Finger of the patient or finger of the examiner. So when you are examining for the subfibular pain on the lateral side, there are so many structures which are all around. So it is that horseshoe shaped type of tenderness or swelling which will specifically tell you about involvement of the subtalar joint. And whenever you are evaluating the movements of the subtalar joint, you have to be very, very much careful, taking the heel in one hand and putting your thumb and finger over the talar body and then you are trying to manipulate your foot into varus and valgus, inversion and eversion, with the flat of the foot resting on the forearm of the examiner. This is what will not give you spurious movements occurring at other joints than the subtalar joint. Thank you.
Thank you, Dr. Rajiv. Another question to you is from the audience, is that subtalar pain is not an uncommon problem secondary to subtalar. Inflammatory doesn't work is fusion. In the good old days, it was recommended that prior to fusion, you put the patient in a plaster cast and make him walk, see whether he or she benefits from this. Is this something you do now or it's not necessary?
See, to really diagnose pain which is coming from, which you feel clinically that is coming from multiple origins, the best thing is to inject that particular area, either under CM guidance or under ultrasound guidance. So that is going to give you a perfect diagnosis whether the pain is generated from that particular joint or not. Giving a plaster in subtalar arthritic patient is not followed nowadays. You may offload the joint, you may give rest to the joint, give analgesics, anti-inflammatory. Sometimes this inflammatory arthritic subtalar joint. How do you differentiate a subtalar joint pathology, which is something which is coming from systemic etiology versus something which is coming from the local etiology? Very simple. A systemic etiology would have a bilateral involvement more than not. So if you have a bilateral symmetrical horseshoe-shaped swelling of the swelling below the ankle, likely that that patient has got subtalar arthritis, synovial arthritis, and these are the cases which may not respond to your analgesics, anti-inflammatory, but might respond well with carefully placed injection of local steroid in and around the joint.
Gautam, can I add one more
Thank
thing?
you, Rajiv. Abhishek, a question to you. Are you around? Abhishek, one of the commonest places the local injection is in the heel. But a large part of heel pain, plantar fasciitis, etc., or heel spur pain is often inflammatory secondary to either uric acid elevation, RA, etc. Now, also a lot of these pains are ups and downs. So sometimes the patient with heel pain says he's better, then it goes off for 3-4 months. Then again the pain reappears. So how useful is heel injection, which is one of the commonest things that is done? Most patients seem to settle down even without that.
Correct. So injections are, as we said, one of the things in our armamentarium. So it cannot substitute to a good clinical examination, which includes a good history. So most inflammatory arthropathies, including gouty arthritis and gout-related like uric acid arthropathies, would have a good history, which will kind of give you certain flare-up factors and relieving and aggravating factors. So if you know it is one of them, then injections will only aid as or only help as just as a mode to tide over an acute crisis of that patient at that time. It's not going to change his internal metabolism, which even after the effect of the injection wears off, will again come back in no time. So it is, if say like a patient of gouty arthritis, heel pain has a wedding in the family, I would inject that patient to tide over that wedding so that he can spend those precious moments with his family with a smile on his face. That is the only job of an injection in an inflammatory pathology.
Right. Thank you very much, Abhishek. I think this session was absolutely fabulous. I would also like to thank Dr. Karkhanis, who did a wonderful job of explaining to us how to manage a routine ankle sprain, which we see so very commonly in the OPD, how to use walking aids, etc., which none of us have ever learned properly. Thank you, sir. And as we move on to the next session, I would find that also I would like to make an announcement that July 5, which is a Sunday again, will be our next Master Care Master session. This session will be on spinal tuberculosis and osteoporotic vertebral fractures, purely from the point of view of the general orthopedic surgeon. So please don't forget to join us if possible, if COVID is over and we are allowed to, we may have a regular meeting. Else, we will continue with these online webinars. Back to you, Dr. Harshad.
Thank you, Gautam. So we start the last session for the day, and I call upon Dr. Roshan Wade, who's going to talk to us about clinical diagnosis and differential diagnosis of knee pain. Roshan, you can start sharing your presentation. Roshan, you're on mute. You need to unmute yourself.
Yes. Is I audible now?
You're audible and visible. Go ahead.
Okay. Can you see my screen?
Yes, I can.
Yeah.
Go ahead.
So today we're going to talk on the clinical approach to the knee pain and how one can go ahead with the clinical diagnosis around the knee pain. And the most important aspect of knee pain is to understand the anatomy, the biomechanics, and the biology of the knee joint. So unless you understand these three things, you cannot be a complete orthopedic surgeon, because John Houston has said that 90% of anatomy and 10% of common sense makes an 100% orthopedic surgeon. So one has to understand the anatomy and biomechanics of knee joint. Remember the 4-bar cross-linkage mechanism of knee joint, which gives an additional stability to knee joint in all direction. And this is what has to be recreated whenever you do trauma, joint replacement, arthroscopy, or any kind of knee surgery. This 4-bar cruciate linkage mechanism has to be recreated so as to get a complete stability of knee joint. In biomechanically, it's a very condylar, two condyles articulating on the flat structure, and this leads to a very unstable situation. Plus there is a patellofemoral joint which adds to the instability when in extension, especially because of increased patellofemoral load in walking and on climbing stairs. So what are the common causes of pain? The sources of knee pain could be from bone, articular cartilage, meniscus, soft tissue, fat pad, capsule, ligament, or it could be because of the malalignment, neurological dysfunction, biomechanical restraints, or it could be structural problem and activity related. So we are going to take each of them in detail. So history wise, if you see a differential diagnosis of knee pain, usually we'll see by location. On superior side, it will be patellofemoral pain. On the lateral side, lateral meniscus tear, lateral compartment osteoarthritis, or iliotibial band tendonitis. On medial side, could be medial meniscus tear, medial compartment osteoarthritis, space incidence bursitis, and plica syndrome. Inferiorly, it could be patella tendon tendinitis, and posteriorly, it could be ACL tear, popliteal cyst. Anteriorly, it could be. So location-wise, all this pain has been redistributed. So one has to point out where exactly is your location. In history, one has to find out whether there's a trauma to your knee joint, so that it can lead to meniscus, condyle, ligamentous injury. Incident onset injuries or vehicular accident injuries we need to take taken carefully. History-wise, you have to see whether it's acute or intermittent. The constant or occasional pain could be because of meniscus and ligament and patellofemoral disorders, and the chronic pain could be because of condyle and synovial problem, which are associated with either rheumatoid arthritis or osteoarthritis. So ACL is the commonest ligament which get damaged. Secondly, is patellofemoral instability and locking because of meniscus. These are the three common problem which you will see in your day-to-day life. Sometimes you can see a locked meniscus. I can see in this video, which is commonly seen in runners or marathoners or gym goers, where they see the locked meniscus and unable to walk and run, and they'll present to in this fashion. So one has to have a systemic approach to this knee pain with the history, site of the pain, character of the pain, onset duration, postural variation, diurnal variation, locking, need of analgesic if any, and referred pain. We are talking about office orthopedics when they have to find out what is the site of the pain. Once you know the site of the pain, if it is a tibial tuberosity pain in young patient, it could be Osgood-Schindler disease. It could be a joint line pain, which is classical of medial or lateral meniscal tear. Anterior knee pain could be because of patellofemoral pain, and the bursitis can mimic the anterior knee joint. The commonest complaints which have been told by the sportsman is locking, clicking, and catching. One has to understand that usually this is seen in meniscal and ligamentous injuries. So what are the pointers? The rapid swelling, popping sound, gradual swelling, locking or clicking, and giving way. These are the commonest problems which are symptoms which are told by the patient. So knee examination includes the inspection, palpation, active range of motion, isometric muscle testing, neurovascular, and certain special tests. So first, most important is the gait. Whenever a patient enters your cabin, first thing you have to see is the gait. You have to see for the pelvic tilt, angulation, and rotation of the tibia onto the femur, because this all will point out some or the other knee pathology where we can miss in them in examination. But one has to be very beware of the recurvatum, because this can mimic the varus, but usually it's not an actual varus, it's a recurvatum of the knee joint which is mimicking like a varus. Range of motion should be tested either in supine position or prone position by prone hanging, because this is the one which gives rise to which gives you conclusion onto the capsular or the ligamentous injury which is untreated or neglected. Sometimes the passive range of motion has got very less clinical value, because it cannot mimic the actual stability of knee joint. So this certain stability tests are very important, because sometimes patient will present as a ligamentous injury. So the commonest one is ACL, PCL, MCL, and LCL. Let's start from the medial side. The medial collateral ligament is the one which gets damaged during the vehicular accident, and sometimes you can see the clinical video here. A grade 3 type of medial collateral ligament which will require some of the other kind of management, and there is a gross posterior laxity in this patient. So you can test them by stress X-ray or image intensifier under C-arm, so that you can quantify this instability. So grading of the laxity can be done as grade 1, grade 2, depending on the joint opening up to 0 to 5 mm, 5 to 10 mm, more than 10 mm. Anterior laxity is commonly seen in ACL tear, usually signifies injury to anterior cruciate ligament, and one has to diagnose this very carefully. Anterior draw test may not be the scientific and most specific test. Sometimes it can give us to false negative results because of door stopper effect of your posterior horn of medial meniscus. Advantages of Latchman is basically it gives you a very good stability test, which can be very specific at 20 or 30 degree of friction, and this can give you a complete patient is less apprehensive and can be done in acute injury scenario. So in this case, you have to flex the knee at 30 degree and try to stress the tibia onto the femur anteriorly. Let's look at the clinical value of each stage. The posterior drawer test has got more positive finding as regards to the posterior sac sign in PCL and reverse Latchman. So this is how one can do the Latchman's test for PCL and to find out the exact instability. So ACL with MCL, certain time you'll get a combined injuries which need to be looked upon, and this combined injury sometimes will give you a complete different picture when you're diagnosing it. So PCL sometimes can present to you with an MCL type of injury, and PCL with MCL sometimes is very difficult to detect on clinical value. So classical pivot shift test has been described to find out the rotatory instability around the knee joint, and which can give you a complete diagnosis of the knee instability. So 20 to 30 degree of flexion, subluxed tibia, deficient knee, especially you can have the malreduction or the IT band slapping, which can be taken into consideration a pivot shift test. As you can see here, classical pivot, interrotation of the tibia over the femur in 20 or 30 degree of flexion, which can give you a complete pivot type of picture. As you can see here, a gross pivot or what we call explosive pivot type of test. Posterior drawer test is very positive in PCL, and you can see here the PCL, you can see gross laxity of the knee joint posteriorly, and this can be easily diagnosed. This is very specific and more sensitive test. It has got a very strong value. The posterior sac test on a relaxation of your quadriceps, there is a posterior sag on the tibia with respect to femur, which can be directly correlating to your knee instability. So cruciate ligament can be, the posterior cruciate ligament can be diagnosed with the quadriceps active test. Here you can see the active part of quadriceps will pull tibia anteriorly with respect to the femur, and this is called as quadriceps active test for PCL. Special test has got certain value. They are found out to be very good, especially the quadriceps active and reverse Latchman. Dial test at 30 degree of flexion, if it is more than 10 degrees, very specific for PCL and PLC injuries, as reported by certain literatures. Posterolateral laxity is very difficult to understand because there is natural laxity on posterolateral corner of the knee joint. External rotation test, varus recurvatum, and posterolateral door sign could be a good way to identify this test in clinical scenario. As you can see here in the posterolateral corner injury, you can see a complete laxity on the posterolateral side. Sometimes it's very difficult to pick it clinically, and one has to have very high index of suspicion. Sometimes you'll get patient who has got very lax knee, which needs treatment, and they gradually are able to dislocate or subluxate their knee voluntarily, and these patients need to be categorically identified because such patients may behave completely different even after surgery or surgical reconstruction of the knee joint. So patellofemoral joint is another part of the knee joint which needs to be taken care of whenever you're diagnosing a knee pathology. Most important is understanding Q angle and J sign. Compression of patella into the sulcus side and displacement of patella by hand can be easily done. Direct palpation of the patella onto the facet could be one, or apprehension test, which is seen in the patellofemoral instability, could be one of the pathognomic of the patellofemoral instability. What is the relation of the patellofemoral joint and Q angle? Whenever you see the force of rectus femoris, which is translated, if your Q angle is more, it tends to lateralize, and this can lead to early J sign, or the contact pressure around the trochlear will increase at 0 to 30-degree angle, and beyond that, it will lead to a subluxation of patella onto the femoral facet. So one has to understand this patellofemoral biomechanics before you land up in the patellofemoral diagnosis. So patellofemoral instability can be easily diagnosed with patellar apprehension test. As you can see in this video, she is a young female who landed up with patellar dislocation, and on apprehension test, she is not able to bend it. But the moment I try to subluxate her patella onto the femur, she is very, very apprehensive. And you can see here, the patella is completely dislocatable onto the femur. So this kind of diagnosis is very, very clear. One has to be very careful when you are seeing patellofemoral tracking, whether the patellofemoral tracking is normal, especially a trochlear dysplasia kind of situation. You will see patella getting dislocated in early 0 to 40-degree range of motion, which needs to be taken care of. So one has to identify this disease, and this can be easily diagnosed clinically. So meniscal test, although it's very difficult to diagnose the meniscal injury, the most important test in meniscus is palpation, that is the tenderness. Whenever you see the medial or lateral joint tenderness, that is diagnostic and pathognomic of your medial or lateral meniscal tear. The commonest tests which are performed in clinical practice are McMurray, Bragrad, and Stevens. None of them have very high index of suspicion, because the specificity and sensitivity of such tests is very, very less. And you can get easily false positive or false negative test results. Child stress can be used in children's or the young adult, but usually it doesn't mimic a good result. So McMurray test is been we have been doing in clinical practice for years. Usually it can be done in 30-degree to 40-degree of flexion. You can do it in 90-degree of flexion as described by certain researchers. And this is how one can do it. Basically, it works on suction effect on the lateral side. So whenever I'm opening on the lateral side by varus angulation, I'm trying to pull my lateral meniscus into the lateral compartment. By doing the valgus stress, I am trying to pull my medial meniscus into the medial compartment. So one has to understand the biomechanics of the knee joint before you plan this such test on knee joint to identify the meniscal injury. So again, after thorough clinical examination, we are back to the same slide where we spoke about the pain and differential diagnosis of different diseases which can be presented in the knee joint, like lateral plane medial pain, which is correlating to medial meniscus or medial compartmental osteoarthritis. Then as a office practice, we commonly do what is known as X-rays, a very important diagnostic tool for an orthopedic surgeon. No orthopedic case is diagnosed without X-ray. The first and foremost, you do X-ray to rule out whether there is osteoarthrosis of the knee joint, there is a degeneration of medial and lateral compartment and patellofemoral joint, tricompartmental. It could be rheumatoid arthritis, which can be easily picked up on X-ray. There could be a traumatic injury to knee joint, which may be missed. Sometimes a PCL avulsion or ACL avulsion can be easily missed during your clinical examination, which need to be picked up on your X-rays. The Sigon's fracture and ACL injury commonly present go hand in hand. Sometimes you'll see a lateral bruise. Sometimes you'll see the avulsion fracture of the lateral margin of the lateral capsule. So this needs to be taken care of, and one has to understand whenever you're reading X-ray, you have to read it very carefully and should not miss this X-ray findings. Chondromalacia patella can be diagnosed very easily. Imaging, you have to check for the MRI, the cartilage sequence, the ligament, integrity of ligament, and the cartilage around the knee joint has to be studied properly. In last, you will see the MRI in your clinical practice. Sometimes we advise MRI on day one, or sometimes we get patient with 2 or 3 MRIs, which has been already ordered by the previous surgeons. Nothing to blame anyone, because MRI is the diagnostic tool for ligament injuries as well as the meniscal tear. You can easily diagnose them. In the last, there is a famous say by Abraham Verghese. It sometimes jokes that if you come to our hospital missing a finger, one have to believe until we get a CT scan or MRI or orthopedic consultation, we just can't trust your senses. It is earnest request to all my orthopedic colleagues and physicians to trust their hands in clinical senses, to bank on the clinical judgment and clinical diagnosis to required for investigation, so that we are not misguided by the modernist technology. Thank you very much.
Thank you, Roshan. A very big topic covered very nicely in the perfect time. You hang around for questions. In the meanwhile, would you stop sharing your screen so I can ask Dr. Sudhir Sharan, who's the next speaker, to share his screen. Dr. Sudhir, are you here?
Yeah.
Please share your screen and switch on your video.
Yeah. Can you see me?
Yeah, I can see your screen, and you can make it full screen and go ahead and take your talk on medical management of knee pain.
Okay. So that was a nice talk, Roshan, and good afternoon to everybody. I have been given a conservative management of knee pain. So I have taken up osteoarthritis, which is a very day-to-day practice in our orthopedic team. So just for a simple slide, osteoarthritis is no more a simple cartilage wear and tear disease. It's a complex multifactorial disease with inflammatory mediators released from cartilage, bone, and synovium. So once the patient comes to me on day one, I just take a proper history about occupation, daily activity level, the onset, duration, and progress of the disease, any specific history, any cracking noise during the knee movements. That's how the common patient tells, awaaz aata hai. Any history of night pains, activities that exaggerate pain, pain on squatting, cross-legged, using staircase, and standing after long hours of sitting, and any history of comorbidities. And if just a focused clinical examination, positive signs to actively look for is an antalgic gait, a clinical varus, any fullness around the knee joint, any joint line tenderness, and just see for the quick range of movement and any crepitus during this movement. So majority of patient presents to me or any orthopedic surgeon is around age 50 to 70 years. They complain of dull aching knee pain, one more than the other, pain on prolonged standing, walking, squatting. An examination, there is a medial joint line tenderness, mild crepitus, and range of movement is generally free. The expectation of this patients coming to OPD is to get rid of the pain. So in my first sitting, what I do, I counsel the patient, explain the patient in the simplest of terms, what is osteoarthritis. And I also do tell them that it is going to deteriorate with time, but with patience and compliance, we can reduce the effect of it. And I also tell them stop worrying about the surgery, because a lot of patients come to me and ask, when do I require a total knee or any surgery? So I tell them stop worrying about it. For right now, we are just going to manage the pain and see the progress of the disease. So my prescription goes like, in the first sitting, I gave acetaminophen, 500 milligram BD for 7 days. Calcium I add, oral vitamin D3 per week, topical gel, and home-based knee exercises. These patients are generally old in Mumbai city. Going to a physiotherapist or visiting other hospital might not be possible. So simple home-based knee exercises. A kneecap while walking or long hours of standing, hot fomentation. I also ask them to avoid squatting and sitting cross-legged. I ask them to follow. So this simple knee-based exercises are straight leg raising exercises or with a back support. These patients generally also have back complaint. So these patients can just support on a long chair and extend and flex the knee. Hamstring stretch exercises, I ask them to just keep their spine straight, press on the knee and bend forwards. So these are the exercises which I tell to the patients. Some of the patients ask me whether I can do cycling, yoga or swimming. So I generally tell the patient, if it is comfortable, you can go about it. Yoga is not a simple exercise, but whatever the patient is comfortable with, I do ask the patient to continue. This aquatic based exercises are newer trend in Mumbai. I would like to often use it as the buoyancy in the water reduces the weight on the joint, but I hope it is more available for common patient. Cost and availability is an issue. So majority of the patients will show 80% of relief with the above measures. They are counseled that the remaining 20% relief they will get gradually according to their work schedule. For those who are not satisfied, in my second visit, I step up to NSAIDs for 5 days and then SOS. I also do add an PPI for 5 days. I this time add glucosamine at the 1500 milligram once a day. I continue with the vitamin D and calcium and continue with hot fermentation and kneecap. I consider taking an X-ray at this level to know the extent of the disease. Generally, it's a weight-bearing knee X-ray, AP, anteroposterior, lateral and skyline view. I will consider physical therapy at this time when the patient complains of acute focal pain pointing to some region of the knee. I don't generally recommend an MRI unless an obvious pointer in the history or clinical examination, because that doesn't change the line of treatment significantly for routine cases. So if you see this X-ray, if you add an X-ray on the left side, you see there is a minimal loss of joint space. On the right, you see there is more loss of joint space. There is a formation of osteophyte, but you will be surprised that such patients, they are also very comfortable in carrying out the day-to-day activity with bad X-rays. So some of the patients are tolerant about it. I don't offer them and surgery at this level also. So my stand on NSAID is I preferably use naproxen at the dose of 250 milligram with PPI or NSAIDs and PPI combination. Risk of GI side effects are high. So if there is a high risk, I prefer atrocoxib 60 milligram and not more than 5 to 7 days, and then on SOS basis, gradually reduce use of NSAIDs by use of other supplements and use it for a longer time. So just a simple diagram how to choose an NSAIDs. There are COX, non-selective COX inhibitors, generally the indomethacin and ibuprofen, and preferential COX-2 are nimesulide, diclofenac, aciclofenac, and selective COX-2 are celecoxib and atrocoxib. So just a slide showing the inflammatory mediators, arachidonic acid, they are acted upon by other enzymes COX-1 and COX-2. COX-1 and COX-2 are again inflammatory mediators which are bad for the joints but good for the GI. They prevent gastrointestinal bleeding. So once you take care of the pain by blocking COX-1, remember these side effects of gastrointestinal bleeding, renal toxicity, and in COX-2 inhibition, which are atrocoxib commonly used, beware of renal toxicity, water retention, and thrombotic risk. Diet and weight loss, regular documentation of weight at every visit just to make the patient conscious that we are seeing at it's an important part of management. If feasible, then arrange an appointment with a dietitian for a proper patient weight loss program. Basic physical activity, I advise for 40 to 45 minutes per day, brisk walking, cycling, swimming, as and tolerated and according to patient profile and pocket. Intraarticular injections will be covered in the next lecture. So they are a part of the treatment on OPD basis. Use of physical therapy, I generally don't use them often, but in certain cases, when there is a specific history or a focal pain, we can consider use of laser therapy, knee taping, ultrasonographic and interferential therapy. Unloaded knee brace, which Dr. Roshan showed us, they are important and they are a part of treatment. However, cost and compliance is a major factor for me to choose this for my patients. Role of these are they are not as a drug, they are not recommended by FDA, but they are food supplements which have been found to be useful are glucosamine, curcumin, collagen, and rosy hip extract. There are a lot of literature about it and they have shown that they do help. However, a lot of AOS and OSI don't recommend that, but it has been a use when you want to decrease the dose of NSAIDs. Curcumin in our Indian setup is a time-tested drug. Recently, Amul has also come with haldi milk, and I recommend at a dose of 100 milligram. This I have been using for last maybe 6 months or so. So there are other literature showing use of diacerin, which is an interleukin antagonist. They can be used. However, you have to keep diarrhea is a side effect. Rosehip extract again used for a longer time. This takes off the dependence on NSAIDs. So just a chart which shows that both the studies, Orthopedic Osteoarthritis Research Society International and AOS both have generally not recommended use, but ORC has recommended use of intraarticular corticosteroids and hyaluronic acid conditionally. I do consider as appropriate in using a walking stick, exercises, strength training, self-management, and educate themselves about the osteoarthritis process and weight loss. Knee braces, sleeves, and foot orthosis do help in certain cases where the cause of pain is elsewhere. In a nutshell, the treatment program should be tailor-made based on the patient morbidity and socio-economic issue, self-education and awareness about the level of disability and expectation, diet and weight management with proper compliance, proper patient-specific exercise program, and use of other non-formal pharmacological modalities so that the dependence on NSAIDs goes down. First choice of analgesic should be topical NSAIDs, especially if GI, renal, or CVS such comorbidities exist. Acetaminophen for milder cases, naproxen, etoposide if required. Add a PPI. Intraarticular steroid shots can be considered for quick and short-term relief. In certain cases of anteromedial osteoarthritis, use of medial unloader braces is advocated. Nutritional supplements and newer medications are a promise which can decrease the dependence on your NSAIDs and be updated on newer and prospective therapy. Thank you, Harshad.
Yeah, thank you, Dr. Sharan. I will call upon the last speaker for today's session, Dr. Nikhil Ayer, who is going to talk about injections around the knee joint. In the meanwhile, faculty for the knee, please stay around for question and answer sessions, which will be at the end of the period. Nikhil, you can share your presentation. Sudhir, please stop sharing your screen.
Yeah. Hi, Harshad.
Yeah.
I'll just share it as soon as.
Yeah. Sudhir, you have to stop sharing your screen.
Yeah, I'm just.
Right.
Yeah.
Yeah. Is it visible?
Yes, Nikhil, you can go ahead.
Yeah. A very good afternoon to all. Firstly, I'd like to thank Bombay Orthopaedics Society for asking me to give this talk on injection techniques for the knee. I'm going to be talking not only about intra-articular knee injections, but I'm also going to touch upon common peri-articular injections around the knee that can be given in an office setup. The various conditions for which one could give injections in the knee during a routine office consultation are for osteoarthritis or other inflammatory arthritis. Injections around the knee are used for Baker's cyst aspiration in case of iliotibial band bursitis, infrapatellar bursitis, pes ancinus bursitis, jumper's knee, or quadricep tendinitis. The various agents which are used for injection are steroids, local anesthetics, or viscosupplements. Among the steroids, most common are triamcinolone acetonide, commonly known as Kinacot, and methylprednisolone acetate, that is commonly known as Depomedrol. In my practice, I usually use Kinacot, as with Depomedrol, some patients experience more post-op injection pain compared to Kinacot. This is said to be due to the preservative rather than the molecule itself. I usually use local anesthetic agents only while giving peri-articular intralesional injections. I never use local anesthetic agents for intra-articular injections for the fear of its chondrotoxic effect. And an intradermal sensitivity test is a rule for all patients in whom I inject a local anesthetic. For intra-articular injection, I usually use 2 ml, that is 40 milligrams Kinacot with 3 ml of normal saline to have adequate volume to bathe the entire joint surface. A 21 gauge by 1.5 inch needle is commonly used. For intralesional or peri-articular injections, I use 20 milligram Kinacot with 1 cc of 2% lignocaine. Usually, a 23 gauge needle is used. Viscosupplements commonly available are Durolane, Synvisc, or Hyalgan. Today, most of us have moved towards single-shot injections in viscosupplements. I'm not going into the details of this because that is a talk by itself. Now, for intra-articular injection of the knee, the two most common approaches I use are the medial approach and the anterior approach. My preferred approach is the medial approach. I use the anterior if the patella glide is poor, that is, if the patient is too apprehensive and holds the quadricep mechanism too tight to give the injection from the medial approach, and or if there is a large osteophyte making the approach not very suitable. Now, for the medial approach, the patient is lying supine with the knee completely relaxed in full extension. I start with marking the upper and the lower poles of the patella. Then I mark midway between these two borders and come down medially to identify the medial parapatellar groove. Gliding the patella mediolaterally helps us identify this groove. The marked injection site is cleaned with beta scrub followed by alcohol. The injection site is infiltrated with 2% lignocaine using a 25 gauge needle to anesthetize the injection site. Although most people I know, including me, just skip this step. The needle is then injected into the joint horizontally at the pre-decided entry point, avoiding too much tilting upwards or downwards. I usually inject 2 ml Kinacort mixed with 3 ml normal saline using a 21 gauge needle. One can appreciate the needle entering the joint by the give-way sensation. If there is effusion, aspiration of joint fluid again confirms position of the needle. Supporting the needle with one hand, the entire drug is injected into the joint. Any excessive resistance to the injection warrants repositioning of the needle. The needle prick site is then cleaned and covered with a routine band-aid, and the knee is put through a full range of motion to spread the drug through the joint. Injecting visco supplements is exactly the same, just that instead of the steroid, the visco supplement is injected. For the anterior approach, the patient is made to sit on the edge of the examination table with the knee bent at 90 degrees. Identify and mark the following: the lateral tibial plateau, the medial tibial, the patellar tendon going down into the tibial tuberosity. Identify the lateral edge of the patellar tendon and trace it proximally to the soft spot. This is just lateral to the inferior pole of the patella, kissing the lateral edge of the patellar tendon. The injection site is cleaned with beta scrub and then alcohol. The injection site again can be infiltrated with 2% lignocaine using a 25 gauge needle. The content of the drug is the same, 80 mg Kinacort made to a 5 ml volume, 21 gauge needle. The needle is inserted parallel to the tibial plateau in a posteromedial direction up to a depth of about 3 centimeters. A giveaway is felt. It's a good habit to always aspirate to make sure you're not in the blood vessel. In case of excessive resistance, withdraw a bit and then inject. After the injection, the site is cleaned and covered with a band-aid, and again the knee is put through a full range of motion to spread the drug. The patient avoids undue weight-bearing activity for at least a week and is then given strengthening and mobilizing exercises to continue at home. Total bed rest for 24 hours after injection is advisable in rheumatoid knee results. Repeat injections can be given at intervals of not less than 3 months with an annual X-ray to monitor joint degeneration. Patients might be waiting for a surgery. The injection should not be given for at least 6 weeks prior to the surgery. Okay, you might rarely want to aspirate a large Baker's cyst which limits active and passive knee flexion. For this, the patient lies prone. Mark a spot 2 fingers medial to the midline of the fossa and 2 fingers distal to the popliteal crease. Insert needle at the marked spot and angle it laterally at 45 degrees. Aspirate the fluid found. Usually a 19 gauge or an 18 gauge by 1.5 inch long needle is used. A firm compression bandage for a day or 2 prevents the bursa from getting refilled. Iliotibial band bursitis is classically seen in runners. The bursa lies deep to the iliotibial band just above the lateral condyle of the femur and is approximately the size of a golf ball. Patient sits with the knee supported in extension. Identify and mark the tender area on the lateral side of the femur. Insert the needle into the bursa, passing through the tendon or just below the tendon, and touch the bone. Deposit the solution in bolus. An absolute rest must be maintained for 10 days, and then stretching and strengthening program can be initiated. Infrapatellar bursitis is seen in runners or in people doing excessive kneeling, or can be seen following a direct blow. There are two infrapatellar bursae, one lies superficial and one deep to the tendon. It is found that the deep bursa consistently lies posterior to the distal third of the tendon. A patient sits with the leg extended and the knee supported. Identify and mark the tender area at midpoint of the tendon. Insert the needle horizontally at the lateral edge of the tendon, just proximal to the tibial tubercle. Ensure that the needle is not in the tendon and deposit the solution as a bolus. Pes sanguinis bursitis is seen in dancers or runners. There is usually pain to resisted flexion of the knee. The bursa lies immediately under the hamstring posterior to insertion. It is important to remember that the bursa is extremely tender to palpation normally on everybody. So comparison testing must be done on both knees to ascertain pathological tenderness. The patient and supported, identify the pes sanguinis tendon by flexing knee against resistance. Follow these tendons distally to where they disappear at the insertion into the tibia. Mark the tender site slightly proximal to the insertion. Insert the needle in the center of the tender area through the tendon to touch the bone. Slightly withdraw and deposit the solution as a bolus. Now, infrapatellar tendinitis or jumper's knee is basically pain at the inferior pole of the patella. While examining, there is pain on resisted extension. For this injection, patient sits with the knee supported and extended. Place the first web space of the cephalic hand on the superior pole of the patella and tilt the inferior pole up. Mark the tender area at the origin of the tendon on distal end of the patella. Insert the needle at midpoint of the tendon origin at an angle of 45 degrees. Pepper the solution along the tendon in 2 rows. While doing this injection, there should always be some resistance to the needle to ensure that the needle is not intraarticular. Lastly, coming to quadriceps tendinitis, which occurs most commonly due to overuse. In this patient experiences pain mainly while going downhill or down the stairs. There is pain on resisted extension of the knee. The usual site of the lesion is on the superomedial pole of the patella. This is found by pushing the patella medially with the thumb and palpating up and under the medial edge with a finger to find the tender area. For this patient, lie on a table, relax with the knee in extension. Identify and mark the tender area, usually on the medial edge of the superior pole of the patella. Insert the needle at an angle horizontally to touch the bone of the patella and pepper the solution along the insertion of the tendon there. I guess I've covered most injections in and around the knee that can be safely given in an office setup. Even if you're doing these procedures in the office setup, never miss out on taking an informed written consent for all these procedures. Thank you.
Thank you, Nikhil. Do we have any questions for the panel, Gautam?
Yes, Harshad, we do have a few questions. I think fabulous talk by Nikhil covered all aspects of injections and very lovely video. How to do it. First question is to Sudhir. Sudhir, are you there? Dr. Sharan?
Yes, sir. Can you hear me?
Dr. Sudhir Sharan?
Yes, sir.
Sudhir, in this time when people have started talking about unicompartmental osteoarthritis and knee replacement, etc., how does one diagnose early unicompartmental arthritis?
Unicompartmental arthritis.
A surgery like a
Yeah. Hello.
Yes.
Can you hear me, sir?
Yes, yes.
Unicompartmental osteoarthritis is mostly on the medial side. The patient will point towards the medial side. It is mostly on standing or walking. So that gives us a fair idea that it is a unicompartmental osteoarthritis. Secondly, if you take a weight-bearing X-ray, you will see that there is a general loss of knee joint on that side. So that gives us a pointer early. But remember, with early stages, the exercises, strengthening of muscles around the knee joint, these patients can pull on for little more long. And generally, if it is a focal pain, like Roshan has demonstrated, an MCL or a menisci tear, if there is a history of twisting or something like that, then patient can do an MRI and diagnose it. But medial osteoarthritis uni is mostly on the medial side.
Right. Thank you. Question to Roshan. Roshan, you had a huge amount to cover within a short time, but the question to you is, you often find patients, especially young to middle-aged patients between 30 to 45 or so, who come with unilateral knee pain and synovitis. So you find a knee swelling. So how does one, that is, if a patient comes with ligament instability, it is very easy, or if you know the test to diagnose that there is an instability. Typically, a McMurray's test or something will give you a meniscal tear, but often you have these knee synovitis or non-specific knee swellings. How do you go about diagnosing and treating these patients?
So I think if I had to reframe your question, it is how do you diagnose a young arthritic knee and a patient who is presenting with swelling and synovitis? Am I right?
Yes.
Yeah.
Yes.
So a young arthritic knee who has got no swelling and synovitis is very easy to diagnose because patient will tell you the symptomatology of knee pain, and secondly there will be a little bit of malalignment in knee, which you can easily pick it out clinically on your gait, a standing X-ray or scanogram. And about your second question of how do you diagnose the swelling and effusion, synovial effusion, one has to have the high index of suspicion. The palpation of the synovium suprapatellar pouch will give you indication, especially the medial side where the muscles are usually easily thinned out, and you can easily palpate synovium. And in those situations, MRI is the diagnostic. Like you are suspecting rheumatoid arthritis or tuberculosis, then I think it's better to do the MRI and diagnose your knee swelling. No patient should be ever treated with injection or any kind of surgery without proper diagnosis. If you're unable to diagnose, I don't mind doing diagnostic arthroscopy and take out a synovium and do a synovial biopsy so as to confirm my diagnosis, whether it is a purely young arthritic knee or say it's a purely tuberculosis or purely rheumatoid arthritis. Sometimes it's very difficult to diagnose the synovitis and the tuberculosis or rheumatoid arthritis only on clinical judgment.
Right. Thank you. Nikhil, you did mention the other chemicals, that all the chemicals that you can use to inject the knee. A lot of emphasis these days is on viscosupplementation. What is your experience with all these things? Whether it is Synvisc or some of the other stuff, what would you recommend to people? Is it worth using? Is it completely useless? There is also the bit about oral drugs, like Dr. Sudhir mentioned glucosamine. There are others who use diacerin. Are any of these really useful? I mean, I per se have always thought that these are all to be thrown in the dustbin. They are useless modalities. What do you think?
Okay, that's in two parts. One about the visco supplement, the other about the oral. As far as the visco supplements, I usually recommend it to early osteoarthritis who are having too much of stiffness, or to patients with severe arthritis who want to buy some time. At the same time, all patients are counseled that not all patients have very good result with this, but we do see most of the patients for around 6 months have reasonable amount of relief. And if they're buying time for a surgery, it's a good enough option. And especially in young arthritis, where they have more of stiffness due to friction, the visco supplement really works well. As far as the brands, there is just one of them is got a protein in it, the Synvisc. The other is a completely artificial, made from bacteria. There's no avian source in it, so it is supposed to have lesser reaction. But I think that is variable from patient to patient. I counsel all patients that they'll have some reaction post the injection.
Sudhir, you mentioned glucosamine, and what is your take on that? And also further, nowadays there are a lot of these drugs. There is a drug called Tendoactive for tendinopathies and all. Are these drugs useful? What is your experience with them?
So basically, to get the patient a lower dose of NSAIDs, and I continue with these food supplements, but I do put them on exercises. So they do help, but alone they cannot do much for the patient. So with exercises, with their change in day-to-day activities, and with decreased dose of lower dose of NSAIDs and with food supplementation, they do help in the longer term of the patients.
Thank you, guys. That's all from the questions from the audience here. And I would like to hand the mic back to Harshad to take you to the end. Thank you very much.
Thank you.
Thank you very much, Gautam. And I would like to take this opportunity to thank all my faculty. There were 17 people here who have been active. I have had presentations with them before this session also. We've had trial sessions. And I think the functioning of this webinar was extremely smooth. And for that, I have to thank Kshitij Chaudhary. I have to thank Swapnil Kini. And I have to thank Gautam Zaveri. All of them have worked very hard to get this seminar to you. And of course, Swapnil is going to put this seminar up for posterity's sake for the following years. People can watch it whenever they want. It is going to be on the YouTube channel. If you have any questions later on, please get back to us. In the meanwhile, from Bombay Orthopaedics Society, I thank all of you for joining us here today. And we hope to see you for the next sessions of the clinical meeting as well as the master course sessions, which we will try to hold on the webinar and if possible, a physical meeting. Thank you very much. Swapnil, you have to say something?
I'd just like to thank all the faculty who've taken out time and done an excellent job at, getting this very, very concise, precise and to the point. And we shall certainly be sharing these videos in whole and in part with all members of the Bombay Orthopaedics Society. And it is also available on the YouTube channel for everybody. And I thank all the audience and all the members for supporting us and really encouraging us to hold these online webinars in such difficult times. Thank you.
Thank you. Kshitij, you can stop streaming.